Hello. 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 Check. Hello. Hello.
Hello, 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 am I checking? Hello, hello, hello. Hello, am I checking? Hello, 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 am I checking? Hello, hello.
For this, and with that, I would request Dr. Ulas to take over stage.
Thank you, Govind. Thank you, Medtronic, for your wholehearted support. I am Dr. Ullas, as you know. I'm the Director of the Cardiac Electrophysiology and Pacing at the Madras Medical Mission. Indeed, gives me an immense pleasure to invite you all to this unique conduction system pacing symposium dedicated exclusively for the pediatric population and the population with congenital heart diseases. If you look back at the history of conduction system pacing in the country, it is, I would say with pride, that it is the Madras Medical Mission in the year 2017 brought the first ever time the conduction system pacing concept to the country by bringing in some of the experts from the globe. To keep that tradition up, Dr. Shivakumar, who is the head of the pediatric cardiology department here, has taken up this initiative. This is absolutely a great initiative because if you really think about the importance of conduction system pacing, I think, which is considered to be a physiological way of pacing, I think it is much more relevant in the pediatric population because these are the patients who are going to be dependent on pacing for a longer time. And especially with the Medtronic kinds of devices now, several challenges of pacemaker implantations in small body frames and complex anatomy. We will be demonstrating you the hardwares. They are very sleeker. And the negotiation of these leads across the various tortuous or difficult anatomy, you will feel that it is going to be much easier than your conventional pacing. It appears to me that in the coming few years, the so-called, even in the newborn period or very infants, small size infants, seems to me that it is going to be the endovenous conduction system pacing. That is going to be the norm. The default technique of permanent pacemaker implantation, I think it is going to be conduction system pacing. You see, if you really are looking at some complex congenital heart diseases with underlying LV dysfunction, etc., well, we have some other modalities, for example, CRTs. But you know what, that CRT is easier said than done. It is like the non-responder rate or the difficulty in achieving the so-called true cardiac resynchronization therapy in children is extremely difficult. But if the conduction system pacing, typically in the coming 1.5 days, we are going to be concentrating more on left bundle branch area pacing. Because the aim of this particular symposium is not necessarily to make the conduction system pacing as more of an electrophysiology. Our goal is not to make this particular symposium to be relevant to the electrophysiologist. We want it to be relevant to all the interventional cardiologists, including the pediatric interventional cardiologist. And the master, Dr. Shivakumar, has developed the innovative technology. He uses the fluoroscopy and some dye and to delineate the anatomy. And it is not necessary to demonstrate the so-called conduction system capture, etc. It's for a purist point of view. What we are trying to get as narrow QRS complex as possible, as normal axis that is possible, and that is possible without an elaborate EP system. So in the coming 1.5 days, I'm sure Dr. Shivakumar is demonstrating his skills, his knowledge, his expertise, and then make you emboldened to consider conduction system pacing as the default therapy. That's what I would promise. So thank you, Medtronic, again for supporting this particular thing. And I hope, like the National Physiological Symposium as what we do it in adults, which is more of an electrophysiology based, I think Dr. Shivakumar and his team would conduct once in a year again, a pediatric dedicated conduction system pacing symposium for the pediatric age group and the patients with the congenital heart diseases and structural heart disease. So I wish you some great time and great learning. And with this, I thank again, and Dr. Pramod might start his the first presentation. Thank you.
Thank you, sir, for the kind introduction. Okay, good evening, everyone. This is a quite tough topic that I am speaking about. This is a lot of molecular basis, which probably is quite difficult to understand, and but it doesn't really matter in terms of the practice that we are doing. So I'll just briefly cover this topic, and there are next two topics which will be discussed again with relation to the anatomy in adults and in congenital heart diseases in detail. So this will be more of a brief introduction only. This is something that we all know. This is the basic conduction system of the normal adult. If we understand it, the cardiac conduction system will constitute only 2% of the total cardiac myocytes. As we know, it's the primary pacemaker is the SA node, and then it conducts to the AV node. Both are actually slow conducting structures if we classify functionally. And then whatever is rest is the His bundle, which is the important thing that we are discussing about today. The His bundle and the left bundle, along with the bundle branches and Purkinje fibers, constitute the fast conducting ventricular structures. If you go to the development, as we can see, this is actually from the mouse model. This is the initial primary heart tube, where we can see whatever is in purple is the basic thing that is there at the initial part of life. And this is usually seen in around 5th week of gestation in humans, whereas in an embryo, actually in a mouse, it's like 8 days. The gestation age of mouse is something like 20 to 25 days, not more than that. So in 8 days, this is what they see in a mouse, whereas in human beings, it's something like 4th to 5th week of gestation, we see a primary heart tube like this. And whatever yellow we are seeing are the sinus venosus portion caudally, and this is the outflow portions. So as there is a development, as we can see, all this purple remains in the conduction system. The SA node and AV node mainly develops from this initial primary heart tube, and rest of the myocardium will arise from the outpouching from the greater and the lesser curvature, as we can see. From the greater curvature, we can see the ventricular mass developing, and from the lesser curvature, we see the atrial mass that is developing. And then this is actually the caudal portion, which actually has the sinus venosus part, which has both the right and the left horn. And we can see here as it infolds, this is the right horn and this is the left horn of the sinus venosus. And this is the right sinus horn where the SA node actually forms. And if we see here, the AV canal region between the atrium and the ventricle is the region where the AV node forms, and the AV canal development is very important for a normal development of AV node. So understandably, many diseases which involve the AV canal, that is the inlet ventricular septal defect, AV septal defects, or the AVSDs, all these things are associated with conduction abnormalities. So coming to some molecular basis of each, if you see the SA node, this SA node, as I was mentioning, will derive from the sinus venosus part and mainly from the right horn of sinus venosus. And if you see here, these are the progenitor cells. These are actually, they doesn't have initial, these are actually the genes that are involved in the development. And we can see here the most important thing that we see is a TBX5, which is very important development of both SA node and AV node. These are all the progenitors which have specific genes, and there will be selective expression of some genes and selective regression of some genes that will lead to formation of a conduction system compared to a normal working myocardium. The cells that give rise to normal working myocardium and the conduction system are not very different. They are initially the same, but what matters is what gene that activates and what will regress over time to give rise to the development of a conduction system. As we can see here, there are various, I don't want to go into the names of all these things. If we see here, these will give rise to a development of SA node, and there will be this TBX5 and other genetic factors which will actually give rise to a program that will generate the intracellular constituents that will give rise to formation of a SA node, whereas these are the normal atrial working myocardium, which are actually inhibited mainly by this NKX2 gene. So what happens is, as I was mentioning, it will be actually there both in the right and left sinus horn initially. So whenever there is heterotaxy syndrome, so whenever there is right isomerism, both the right and left will be retained, and they will have dual sinus node. Whereas in a normal individual, the SA node will be restricted only to the right sinus horn by a gene called PITX2, which is responsible actually for asymmetry between the right and left in the human population. So basically, these are some genes that are essential, and the absence of this, or if the mutation in this, will lead to abnormalities involving the SA node. So anatomically, if we see, so this is the location where the SVC-RH junction is, and this is the region of crista terminalis, sulcus terminalis externally and crista terminalis internally. This is the region where we can see the fully developed SA node, and the initial SA node can be even detected at 5th week of development. Here, if we see the histological section, we can understand that this is mostly an epicardial structure. Here we can see this is the SA node here in the blue stain. This is and we can also see an SA nodal artery, which is also in the epicardial surface. So we can see this is the endocardial surface, and this is the crista terminalis portion of the endocardial surface. So whenever there is a surgery involving the sinus venosus defect, the surgeon will operate from externally, where there is a chance of damaging this SA nodal artery, and there will be gradual deterioration of the SA nodal function, and that is the reason why they develop sick sinus syndrome after sinus venosus surgery. Whereas in transcatheter means it will be internal, and this is the epicardial structure that will not be affected by the cover stent that we use. So that is the basis how we are using it without any problems. So coming to the AV node, as we know, I was mentioning that the primary heart tube also forms the major part of the AV canal, and that gives rise to AV node, AV ring, and the base of left ventricle. All three will develop from the similar structures. And as I was mentioning, again the same thing happens here. There are few genetic get activated, and that will give rise to the molecules needed for the function of an AV node, and rest will be suppressed, so that it will become a AV node rather than a working myocardium. So this is also important, this is also like seen in around 5th week of gestation, and it is also known that there will be 2 AV nodes usually, both anterior and posterior, and as there is a development, the anterior and posterior AV nodes will fuse, and it will be predominantly the posterior AV node that is left, which will then connect to the ventricular structures, forming the AV node and AV bundle. Whereas this is the case where in the case of AV discordance, that is in the CTGA, there is a malalignment of the atrial and the ventricular septum. So this will prevent this fusion of the dorsal and the ventral conduction system, that will lead to what is known as dual AV nodal physiology that can be seen in these cases with CTGA. And it is also known that the posterior and the anterior nodes are linked by a sling which cross across the pulmonary annulus. So whenever there is a large pulmonary artery, they are at a higher risk of developing AV nodal block because the sling is quite long, and as it enlarges over time, there will be degeneration of the sling. Whereas in those with pulmonary atresia in a CTGA, they are at a less risk of developing AV nodal block because there is no growth of growth of pulmonary artery in those patients, leading to this progressive elongation of this sling of tissue connecting the posterior and anterior AV node. This will be discussed in the next session. So coming to this fast conduction system, I am not going to this again. This also involves multiple, the same factors. When we see the anatomy of the His bundle and bundle branches from the RV surface, this is a surface, is the right ventricular surface. Here we can see that this is the atrium, this is the ventricle, this is the outflow tract and the pulmonary arteries. This is the membranous septum. Here is actually a beautiful dissection which shows the AV node over here. This is a triangle of Koch as we see. This is the coronary sinus ostium, this is a tendon of Todaro, and this is the base of septal tricuspid leaflet. And as we know, this is the region where there is the AV nodal is located. And as we see here, this is the right bundle branch. The right bundle branch is relatively thinner branch as we can see here. And as it progresses, part of the right bundle branch will pass through the moderator band into the free wall of the right ventricle. So if you see the conduction in the conduction system on the left side, once it pierces from the AV node through the membranous septum and then divides, what we see here is the right coronary leaflet that is seen over here, and beneath that is the perforating bundle of His, and then it divides into right, which I saw on the other side, and it is the left. Here we can see, compared to the right bundle, which was a thin fiber, this is actually a broad fiber which is actually located on the leftward wall of the septum. The left bundle branch, which is here, again divides into posterior and anterior fascicle, which we usually describe. This is also something described as septal fascicle, but for clinical use, we always just take it as superior, like anterior and posterior fascicle. As we can see here, it's a quite broad fiber. So it is the region where we can actually do the conduction system pacing more easily, because as we can see, when compared to the location of His, which is very small, this is the broad area where we can easily capture the left bundle branch. And LBB pacing is quite easier because of this broad fan of conduction system that is there. Even if we come here, whenever the voltages are more, it will have a non-selective pacing that is possible, and we can achieve it. The first thing, this was first actually described by Sano Tawara, he's a pathologist from Japan, actually, who actually made this description in 1906, which is actually the basis for understanding the conduction system, the left bundle, mainly the bundle branch in most of the current understanding is based on this. So if you see something about the fluoroscopic anatomy, which will be discussed in more detail tomorrow. This is mainly the two views that we use is right RAO 30 and LAO 60. This is mainly for a structurally normal heart, but however in abnormal heart it may be different, but otherwise in a RAO 30 and LAO 60 views, we will be able to see the septum in an en face view, and in a 60 we will be seeing the septum in a vertical view, where we can actually see the septum will be somewhere like this, and we will be seeing the lead which is perpendicular. It will give the location where it will show the en face view of the septum. So as I was mentioning about the AV node, some things again important are this TBX2 and TBX3 are actually very important in the development, where they actually suppress the expression of few genes, and if this doesn't happen, there will be development of communication between the atrial and ventricular surfaces, and there is and there is a gap in annulus fibrosis that will lead to WPW syndromes. And as we all know that TBX5 mutation is something that is very common, and the syndrome is called Holt-Oram syndrome, which is associated with commonly with ASDs and limb abnormalities, mainly radial radius abnormalities. It's also found that there are various genetic loci has been identified over time that are associated with prolongation of PR interval. So coming to basic about the neural crystals are not directly involved in the development of conduction system. They are mainly, but they are very essential, because it is found that though they undergo apoptosis over time, they will actually uh, be essential, because whenever they are ablated in animal models, it is found that there is problem with development of the working myocardium. So it is found that neurocrystals are very essential in development, and mainly they have a role of induction in case of in cardiac conduction system, and they will all form ganglion cells around this conduction system, which are actually essential for sympathetic and parasympathetic uh, activity that will cause changes in the heart rate and all other functions. And just one slide about neonatal CHP, because this is something that we see commonly, though this is not very straightforward related to a development. It is a normal development that happens in a child, but usually by the age of just 4 weeks, there is expression of this SSA antibodies, SSA antigen on the surface of this conduction system, mainly in the AV nodal region. This happens during the apoptosis of few cells that occur within this conduction system, where during the process of apoptosis, there will be expression of these antigens that is usually the SSA, also SSB, and these antigens are exposed during this period. So at this period, whenever there is a translocation of the anti-Rho and anti-LA antibodies from the maternal blood into through the placenta happens, it can actually go and bind these structures and lead to inflammatory damage and fibrosis of the AV node. So this is something that is very important. So the treatment of patients, like prophylactic treatment, is usually started by 10th week of gestation to prevent with immunosuppression to prevent the development of AV nodal damage in these patients. So to conclude, development of cardiac conduction system will involve multiple genetic factors. Few are identified and few are still yet to be identified. Most of the understanding is actually from animal models, but however few human studies are available. The various genes which are involved in the development of conduction system are also involved in development of cardiac structures, which is very important, and that is the reason why many congenital heart diseases are associated with conduction abnormalities, and more importantly, surgeries involving these abnormalities are also will also predispose for damage of conduction fibers in these cases. Thank you.
I thank the organizer for the opportunity. I'm Dr. Saikaran from Sri Chitra Institute. So I'll be, next 20 minutes, I'll be covering briefly about anatomical variations in conduction system of different congenital heart disease. It's a vast spectrum of diseases, as you know, but I try to cover major important congenital heart diseases, which is very commonly seen in practice. So this will be the outline of my talk. I'll give brief introduction about normal human anatomical conduction system in a structurally normal heart, which is already alluded clearly in the previous. Bispecific lesions, predominantly VSD and AV canal defects, CCTGA, TOF and TOF DORV, and if I have time, I'll cover about single ventricle physiology also. So as previously alluded, the normal conduction system axis starts from the SA node, which is at the SVC-RA junction, followed by the AV node, which is in the apex of the Cox triangle, which is piercing the central fibrous tendon, just beneath the this translucent membranous septum, which is having two parts, that is atrioventricular component and interventricular component. You can see here the yellow part is the atrioventricular component, which lies between the right atrium and left ventricle. And the blue part is which lies beneath the tricuspid valve, which connects between two ventricles. So is the thinnest part in the ventricle, below which his bundle of his penetrates into the central fibrous body. After penetrating, it reaches the septum, the apex, the crest of the septum, where it divides into, this is the crest of the septum, where it divides into the superficial right bundle, which traverses along the right side of the septum. And on the other side, it gives a thick branch, left bundle, which is again divides into thin left anterior fascicle and thicker posterior fascicle. In a structurally normal heart and situs solitus, you will have anatomical depiction will be like this. AV node will be at the Cox triangle. There it is close to the NCC, the his which is close to the NCC and RCC. It traverses there and it reaches the septum down. So this is just to depict the serial sections at this area. You can see this is the fibrous, central fibrous body where you have the AV node. As you gradually like section further anteriorly, you can see there is a bundle branch, that is the unbranched his bundle, followed by it is dividing into left and right bundles as we go down. So coming to first congenital heart disease, VSD, which is commonly seen in our day-to-day practice. The terminology is very variable when it comes to VSD. So I'll be using these terms commonly. So one is perimembranous defect, which is closer to the central membranous portion of the septum. The other one is the outflow VSD, which is also called as doubly committed VSD, which is beyond the perimembranous area, and it is in the outflow region. It is also called as outflow VSD. Depends on the location of the muscular VSD, it is called as muscular inlet, muscular trabecular, or muscular outlet VSD, when it is in the muscle, like a muscular portion of the ventricle. So coming to the first perimembranous VSD, as you can see, the central defect is which is closer to the perimembranous area. This is our membranous septum. The VSD is closer to this area, we call it as a perimembranous VSD. When you see through the VSD, the roof of the VSD, you can see the aortic cusps, which is formed here. The aortic cusps are there, whether it can be NCC and RCC. You expect the prolapse of the same things there. And also the inferior and the inferior and posterior margins are formed by our conduction system. So there lies our his bundle, which is traversing along the inferior posterior margin of this conduction system. But superiorly, it is well bordered by our septomarginal trabecula, which is having a Y-shaped band. The inferior band will be bordering the superior rim, and the upper Y will be going to the outflow tract. So in this type of VSD, it is very commonly to have associated with the congenital CHP during repairs, because when you take the suture bites, if by the surgeon, if suppose it is very superficially located his bundle, so this sort of defects will be more prone for the complete heart blocks. So when the perimembranous VSD further extends down to the inlet, we call it as perimembranous VSD with inlet extension. As it further dips down, as we already noted that this is the area where our central fibrous body is there, which attaches the atrium and which connects the atrium and ventricle. There lies our AV node. As the VSD further dips down because of the fusion defects, as a result, the AV node will get pushed posteriorly. As you know very well, this is the Cox triangle, the CS os will be here, and this is the apex of triangle. Usually the apex of triangle should be lying somewhere here. Because of the VSD, it goes pushed to more posteriorly. And as a result, the Cox triangle becomes smaller. And like similar to our perimembranous VSD, his bundle runs at the posterior inferior border of this VSD. So these sort of defects also more prone for complete heart block during surgical repair. And the next set is, this is like dominantly you can see here, there is a big VSD at the inlet portion, which is extending to the perimembranous area. This is called as inlet VSD with perimembranous extension. As you can see this, similarly, where we saw previously, in the previous perimembranous VSD, the AV node was located just posteriorly, but still the Cox triangle is bigger. As you go, as the VSD approaches more towards inlet, it will be pushed to more, the Cox will be very narrow. Once it reaches the, basically if the defect gets more closer to the inlet, the AV node will be much posterior. It is almost the CS, there is a very subtle margin between the CS and node. Your site of AV node will be here, almost anterior to the CS. The triangle of Cox will be empty, and the AV nodal will be just anterior to the CS ostium. And his bundle branches will, as usually, it will go along the posterior and inferior rims of the ear VSD. Because of usual, as previous speaker already told, some of the patients will, some of the defects will have the dual AV node dual AV nodes will be there. So this is the regular AV node location. In these sort of patients, you may have the AV node in regular location as well, but it may not have connections, as because there is a VSD, there is a discontinuity is there, so it fails to extend its continuation further down. So as a result, the posteriorly located anomalous conducting node will be there, which is having a good connection with the His bundle. So because of this, sometimes inlet VSD will have the left-sided fascicles will be underdeveloped. So that is the reason where more prone to be left axis deviation in the ECG. The commonest fascicle which appears to be underdeveloped in these sort of cases is the left anterior fascicle. So that's why you'll get a left anterior hemiblock in ECG, in particularly inlet VSDs. So this is the another type of ECG, where another type of VSD where you see there is it is still at the inlet, but it is surrounded by the good amount of muscle, and it is very away from the usual inlet and near perimembranous area. This is the inlet muscular VSD. Usually in these sort of VSDs are well away from the conduction system. If at all conduction system it is there, inlet muscular VSD will be bounded by our his will be traveling along the superior border of this inlet VSD. Then the AV node will be located in its usual place. Needless to say, the distal muscular VSDs and outflow muscular VSDs are well away from the proximal conduction system, but they can be still very close to the distal conduction twigs. So then next coming to this is the outflow perimembranous VSD. You can see this is the VSD is still located at the perimembranous area, but predominantly it is extending to the outflow. So this is called as perimembranous VSD with outflow extension. So this sort of VSD, as like a previous VSD, there will be a malalignment, and also it is superiorly it is bounded by the aortic cusps, and inferiorly it is bounded by the His Purkinje system. And the His will run to the posterior and inferior border of this VSD. Similarly, this sort of patients will also have more risk of perioperative CHP. The next set of VSD is like outflow muscular VSD, which is called as the doubly committed VSD, where you can see this is the Y shape our previously described septum. Inferior limb of Y is actually forming the inferior and posterior border, and the superior limb forming the anterior border. Superiorly, it is bounded by your aortic cusp, and because of there is a doubly committing nature, it is also bounded by the pulmonary artery. So because of this thick muscular ridge, it is actually his conduction system is being protected by this septomarginal trabecula. These sort of patients will be at less risk for the perioperative CHPs. So in summary, for VSD patients, usually the conduction system will be posteriorly, inferiorly located, particularly in central perimembranous VSD or inlet aligned or malaligned VSDs. Whereas with cross malalignment in case of inlet VSD with perimembranous extension, they will have left axis deviation because of underdeveloped left anterior fascicular block. Doubly committed VSD will be protected because of the septomarginal trabecula. So the next set will be AV canal defect. It is like extreme form of the inlet VSD. As you know, the AV canal defect, the central defect lies at the central fibrous area, where there is a defect in both in the septum primum area of the ASD and the central part of the ventricular septum. So there you can see there is a punched out kind of thing is there in the exact central fibrous body where our AV node lies. So as a result, AV node shifts posteriorly as we saw in the inlet VSD's case. So here also this is the CS, AV node lies anterior to the CS, and it is displaced from the Cox triangle. Not only that, see when you compare with the normal anatomy, instead of locating here, the AV node shifts too much posteriorly. So because this is the place where the atria and ventricle comes and joins, so that is the place where it got disrupted because in AV canal defects. That's why the entire conduction system shifts posteriorly. So not only that, when you see here, this is the penetrating part of his bundle, which penetrates the proximal septum, and it lies as usual like a posterior inferior part of our VSD. Not only that, in other cases, you saw as soon as it penetrates the septum at the crest of septum, it usually branches out and gives left and right bundles. Whereas in case of AV canal defect, it has a considerable long portion with his being traveled along the course of the inferior margin of the VSD. So it is the peculiar part of the AV canal defect. So where his lies very much in proximity with the inferior margin. After traveling at some distance, then only it gives the right bundle and left bundle branches. So this patient also will have more risk of complete R block if during corrective surgeries. When in comparison with the different sorts of AV canal defects, you might have heard about a partial AV canal defect where you have the shunt is at only atrial level, partial AV canal defect where the shunt is only at the ventricular level, or transitional kind of AV canal defect. So in case of partial AV canal defect with only atrial component, where you can see the defect is predominantly at the atrial level. As a result, the AV node will be shifted more posteriorly, as like our previous case. In this case, Cox triangle is displaced and the AV canal shifts more posterior towards the CS. Here also, if the VSD is having both atrial and ventricular component, the similar sort of mechanism happens like the only atrial component. Whereas in the ventricular component, if you see, it is predominantly located down. As a result, Cox triangle is hardly, it will not change much, and the AV node will be at the usual location. There's the only positive aspect with the ventricular component of like partial AVCD. By echo, usually you will have shunt at the atrial level, that is partial AVCD. If the shunt is only at the ventricular level, that is partial AVCD ventricular type. These are surgeon's view. Surgeon, we are seeing from the right, we opened the right atrium and we are seeing the right atrium and right ventricular part. So, and another aspect of the partial and complete AV canal defect is, so once it travels in case of complete AV canal defect, his bundle after piercing the septum, it travels more towards the left side of the septum and it is all naked and the entire thing is exposed to the surgeon's knife. Whereas in partial AV canal defect, because of this bridging leaflets, it is partly covered over the septum. So the key features in AV canal defect is the inferior and posterior displacement of the AV node, and left bundle, similar to the inlet VSD, left bundle, left anterior fascicle to say particularly, which is hypoplastic, which is causing left axis deviation. Needless to say, the central fibrous body is absent in these cases. The Cox triangle is always empty in case of atrial predominant or by both cases of IVCD. So the next set is like TOF and TOF variant I'll be discussing briefly. So as you know, the TOF is predominantly caused by the anteriorly displaced outflow septum, which causes the subvalvular RVOTO, which also contributes to malalignment of VSD and also aortic override. You can see here, this is the VSD, which is in the outflow septum, and you can see the aortic valve orifice from that, and it is aortic override is also there. And this VSD is well bounded by this septomarginal trabeculae. The inferior limb is bounding the inferior and posterior margin of Y is bounding the inferior border, and the superior anterior border is bound by the another limb of the septomarginal trabecula. And when you see the his is actually below the septomarginal trabecula. So in case of regular TOF, usually the conduction system will be protected by this ventricular infundibular fold, which is uniting with the septomarginal trabecula. So in a usual TOF outflow VSD, conduction system damage will not occur generally. But whereas almost in 60 to 75% of the patients, the outflow VSD will extend up to the perimembranous area. So as usual, our conduction system defects will be there if it extends to the perimembranous area. So this is a typical example of the outflow septum where you can see the conduction system. It is perimembranous, this is perimembranous portion of the septum. You can see this is the septomarginal trabecula, and this is hypertrophied SM septomarginal trabecula. And this is outflow. It is the specimen collected from the post-operative TOF. You can see the VSD is well away from the conduction system axis. This is from the right side when we are seeing, and you can see from the left side also it is well away from our usual location. So this is particularly holds true for only typical outflow located VSDs. When it almost, as I said previously, 60 to 75% of the VSDs will have some inlet extension. So in those cases, similarly like the previous VSDs which we told like inlet VSDs, the conduction system will be running posterior and inferior margin of the VSD. So these VSDs, surgeon should be very careful during operating these sorts of VSD. So another unusual variant is like a oval shaped VSD, where you can see the defect is oval shape and it is extending just near to the perimembranous area. Because of this oval shape, and there is an acute like a border forming between the posterior and anterior borders, the conduction system may be closer to that VSD. This VSD is also more prone for the complete R block during surgeries. So next comes to DORV. DORV and TOF is like the degree of override and interarterial continuity will be there. That is the subtle differences between TOF and DORV. When it comes to VSD, the location is also same like a usual TOF. It is outflow VSD, which is well away from the conduction system axis. This is your septomarginal trabecula, which is well bounded by the inferior and posterior rims of your outflow VSD. This is a small restrictive VSD where you can see it is located just above the perimembranous area bounded by the septomarginal trabecula, and the conduction system axis is much away from the VSD location. So the important things comes when the DORV, when we are planning for a biventricular repair, surgeon usually extends the VSD and makes it bigger. So there comes the problem. If you extend VSD down, it can cause the conduction system like damage, obviously. So he should extend upwards or anteriorly. So the next set of conduction system anatomical variation is complete corrected TGA. The usual in a situs solitus corrected TGA, usually there is a double discordance. That is, there is a discordant atrioventricular connection, and another discordance is at the ventricular great artery level. So usual arrangement is like right atrium is connected to the morphologically left ventricle, which is on right side, and it is again connected to the pulmonary artery. On the left side, it is left atrium, which is connected through a tricuspid valve into the morphological right ventricle, and it is connected to the aorta. And the aorta is usually left and anterior. So as needless to say, because ventricles are inverted, similarly bundle branches goes along with the ventricles. So the left bundle will be located on the right side of the septum, whereas the right bundle is located on the left side of the septum. So the major factors which decides the orientation of conduction system are, one is interseptal malalignment, which I'll be coming in next slide, and the degree of pulmonary stenosis or pulmonary atresia. Another one is whether VSD is there or not. So the first factor is the septal malalignment. As you can see, this is the normal situs solitus patient. You can see tricuspid valve on right side, mitral valve on left side, the usual Cox triangle location of the AV node and conduction system axis. Here in normal heart, usually the AV septums both are located parallelly, and there is no malalignment. Whereas in case of corrected TGA, you can see in case of no pulmonary stenosis, that is no pulmonary atresia, pulmonary trunk is patent, where the pulmonary trunk get itself wedged into between the two annuli, mitral and tricuspid annuli. As a result, the ventricular septum will be like this, and the atrial septum will be like this. Due to this gross malalignment, there is anatomical variation of the conduction system. Whereas not in, like in the pulmonary atresia, where the pulmonary atresia or stenosis, the pulmonary trunk is normal or like small, narrow. As a result, the malalignment will be minimal. So in these cases of CCTJ with pulmonary atresia or pulmonary stenosis, conduction system may be near normal. Whereas in case of CCTJ with normal pulmonary artery flow, you may have malalignment of conduction system. You may have congenital abnormalities in the conduction system. So, so this was that which the previous speaker also telling. If you have a pulmonary trunk, you can see here this is the left anterior aorta. This is morphologically left ventricle on right side, morphologically right ventricle on left side. You have two AV nodes. This is one AV node and this is another AV node. Because of the malalignment of the septum, see the septum both are like this. If both septa are like this, the conduction system can't travel from the atrial end to the ventricular end. So that's why there is a accessory AV node which occurs at the anterior portion of the morphological left ventricle. That is at the anterior mitral annulus, which is closer to the right atrial appendage. So from there, it takes a longer course. You see here, this is an anterior node which takes a longer course around the pulmonary trunk. That is the longer his. That is because of this taking a longer course around the pulmonary trunk, this is more prone for the degeneration. The other AV node, usually anyway, it will not be connected to the usual conduction system axis because there is no direct connection. This is in case of the patent pulmonary artery. Whereas in case of the pulmonary stenosis or pulmonary atresia, you can see here, where there is no such malalignment. As a result, the normally located posterior AV node may still have communication with the his bundle. So this is the important difference in case of pulmonary stenosis and patent pulmonary artery in case of CCTG. And then coming to distal branches, you see here, this is the posteriorly located AV node at the coronary sinus ostium, and this is the anteriorly located AV node, which has to go around the pulmonary artery to reach the bundles. And also, you can see a small VSD here. presence of VSD, when the bundle of fish comes and it forms the anterior border of this VSD in case of CCTJ with VSD. And as I already told, ventricles got inverted, conduction system also gets inverted. So here the left bundle is on the right side, and the right bundle is on the left side. So this was the communication which exists in few patients, where the anterior AV node and the posterior AV node will get communication, something like this. This is the anterior AV node, which is traveling around the pulmonary annulus, reaching the distal conduction system. This is the posterior AV node, which is closer to the coronary sinus, having a sling through through septum. So that is called as Monkey-Burke sling. So what is the importance of this is, like in case of congenitally corrected TGA, patients will have incessant AV and RT or incessant node-to-node, twin node re-entry tachycardia, what we call as. So in those cases, there will be antegradally conducting through the slow pathway here, and retrogradely it will conduct through the fast pathway, which is connected at the anterior node. So you have to sacrifice one node to get rid of the tachycardia. Usually we ablate the posterior AV node, which is often diseased. Sometimes maybe anterior AV node is much diseased. We need to sacrifice which AV node is diseased. That AV node we have to ablate to get rid of the incessant tachycardia. So, so in case of like conduction system pacing, when it comes to CCTGA, because the left bundle is readily accessible from the right side, so if you pace the ventricle from the right side itself, the left bundle will capture. But the most common, like the right ventricle, which is the systemic ventricle, is supplied by the thin right bundle. So previous studies which showed the pacing of the left bundle itself will suffice, will activate retrogradely and can capture the right bundle within no time, so that the synchrony will be maintained. But still, like in our center, we did some 3 cases where the selectively right bundle was captured and the synchrony was maintained. I'll come to those case aspects in the at last. So the next set of lesions is like single ventricle lesions, where you have, I'll be telling briefly about double inlet left ventricle, which has, as you know, like 3 types, A1, A2, and A3. A1 is normal related great arteries, that is Holmes heart, where the most common is the type 3, that is left and anterior aorta. You can see this is the type 3 DILV, where the aorta is left and anterior, and the hypoplastic chamber is on the left side. And your conduction system will closely mimic your kind of CCTGA, where there is a dual AV node will be there, and the anterior node will be connected around the pulmonary trunk into the septum. Septum will be located here, and this chamber is hypoplastic because VSD is there. It just goes anterior to the VSD, as we saw in the CCTGA case. And the second one is type 2, where the hypoplastic chamber is on right side, and your aorta is on right and anterior, where usually in those kind of cases there will be twin AV node also. You have interconnections between these 2 AV nodes, and the conduction system will branch according to the ventricular pattern in these AV nodes. So I'll just quickly, if I have time, I'll just quickly show one case. So this is the case which I was talking about, CCTJ, where in our hospital we did conduction system pacing. Because it was in the beginning, so we mapped the both fascicles with the HD grid with the help of Insight system. We mapped, this is the right ventricle, right-sided morphological left ventricle. This is the left-sided morphological right ventricle. We mapped the conduction system on both sides. We tagged all fascicular potentials on right and left sides. Then we identified the the anterior his duration HV interval was 35, and the posterior HV interval was 38 or something. So we got separate HV intervals for the both AV nodes. And then after that we tagged the left-sided right bundle. Then we identify the point on right side, and we used the same conventional 3830 lead to penetrate into the septum to target this left-sided right bundle area. With routine conduction system capture, initially there was a notch at the proximal ascending limb. As we go further deeper, the notch ascends up and becomes QR in the later ECGs in V1. This is a bipolar pacing in one of the patients, where initially there was anodal and cathodal capture was there. At 3.5, there is a loss of anodal capture, that is anodal capture threshold, and the selective left bundle and cathodal capture is there. So these are the 3 patients which we have done in our hospital. All 3 patients preoperatively had second patient got AF-CHP, first patient, third patient has CHP. Post procedure, they have reasonable good QRS. All these 3 patients we did with lot CRT because of the initial time. So we are not sure about the further long term. So we put an additional CS lead for an incremental benefit. So in all these patients are doing very well without any LV dysfunction on follow-up. All the 3 patients QRS were in between 100 to 110. Thank you. Yes.
But the distal portion is robust and it's well formed only. So can we target that, because this His bundle is not the same as our normal His bundle. It is not surrounded by surrounded by fibrous structure. It is in the muscle only. So there is there a possibility like that we get a better sensing parameter, better pacing parameter, and the stability is also good,
Yes.
without the need to go the entire depth of the septum?
Yes, sir. The Vijay Raman sir has did one patient with his bundle pacing, but long-term follow-up not published. But acute result was very good. It was no need of left ventricular lead also. With alone his is fully corrected. But because as we said already, the entire his is going around the pulmonary trunk, future risk of degeneration also might be there.
Okay.
Maybe at one point of time, we may have to go with the distal conduction system capture.
Actually, what they say, sir, even with complete AV block, the distal is near normal.
Yes, but here in this case, it is going along the pulmonary trunk. So because
Maybe,
as the
yes.
annulus dilates, future risk of degeneration might be there. That is the cause of.
Yes. And if the center does not have a 3D mapping technique,
Yes,
then
agreed.
probably it is best to target the left bundle, which is on the
yes,
right side.
right
And
side.
the target is still big, sir.
Big.
It's like a fan.
Yeah.
And still the right bundle on the left side is like a band only, single band. So it may be more prudent to target the proximal left bundle, as you said.
Yeah,
Few studies are there.
There is nothing much, like 15, 16 cases were being done along with a multicentric study. They have demonstrated direct left bundle pacing, which is on right side.
Right.
But still they have good results.
Yes.
Further progression of heart failure under like less likely, because the left side it is a small tweak. It is getting retrogradely activated very fast. But still, in a more physiological way, if you capture the right
Systemic
bundle, it is
ventricle.
ideal.
Yes.
But still, right ventricular side, it is more ideal. Whereas capturing left bundle is not bad.
Yes. So in your experience, did you find any coronary sinus tributary abnormalities? Because in CCTGA,
it is described. Yes.
CRT is the usual norm when there is systemic ventricular dysfunction, sir, and AV block. But the CS tributaries may not be normal. In some 1/5 of cases, it may be abnormal.
Yes, actually, few cases we have seen that CS anomalies are there, like osteal atresia, different position of ostium, and still because the right ventricle is on the left side, which is having less CS connections.
Yes, yes.
All the posterolateral veins will come along with the left ventricle, which is morphological placed on the right side, which is acting as the right ventricle. So technically, theoretically saying veins are less, but more or less the epicardial connections will be there, which is draining the left-sided morphological right ventricle. So in all the 3 cases, LV lead boundary was not very difficult. We could achieve easily. Yes.
Coronary sinus lead was put in all.
It was like usual way in all the 3 cases. The other cases which we saw was like routine pediatric cath cases. Those have significant osteal abnormalities. Other things were there, but in these 3 cases we didn't find any abnormalities.
Thank you. Thank you so much.
Thank you, Dr. Sai Kiran. It was we requested Dr. Narayan Nambudri, the professor of cardiology, and he was initially planning to give this lecture online, but then Sai Kiran was so good that he decided to come all the way from Trivandrum. Sai Kiran works with Narayan Nambudri. I had to come a little late. At the beginning of this meeting, I was not there. So, on my behalf, I welcome each one of you. I just want to tell a few things about this institution. Madras Medical Mission was initially conceptualized in 1982. So in Chennai, when Dr. K.M. Cherian came back from Australia and was establishing a program at Railway Hospital, sometime in 1982 he decided to come out of Railway Hospital and start a standalone institution which is called Madras Medical Mission. So in 1982 there was no space available, there was no hospital available, so he took the premises of Vijaya Hospital, which was already an established hospital here. So one of the floors was taken off as Madras Medical Mission, and it was a time when there was not too much of work in pediatric cardiac surgery as well as adult cardiac surgery that was done in Chennai. So he made a huge impact on patients who were operated between 1982 to 1992. As the Madras Medical Mission grew in its popularity, the board decided to invest on a land, and then came this hospital. So this hospital came up in 1992, and then today we are in 2025. This foundation of this Madras Medical Mission was by Dr. K.M. Cherian, the legendary visionary who thought about establishing a private cardiac center to give high-level quality care, research, training. The philosophy continues even today. Even today's attempt to have this pediatric pacing symposia is in line with the thinking of MMM, which is to spread the knowledge, to share the knowledge and disseminate the knowledge. So the founding father of this hospital was Dr. K.M. Cherian. We all know that his mortal remains are in display today in Frontier Lifeline Hospital, and tomorrow morning is going to be his final cremations. As a mark of respect to the great visionary leader, I would request 1 minute of silent prayer. Thank you. We all in this institution strongly feel that we will continue to get his blessings in all the endeavors that we plan out in future also. Coming to this particular meeting, Dr. Ullas already pointed out, the intention of this meeting is to explain pacing, that is conduction system pacing, in the younger patients who are operated for various forms of congenital heart disease, and patients who have certain peculiar congenital heart disease which are notorious to develop complete heart block. So if you look at it, it will come into 3 subsets. Number 1 is small children who have structurally normal hearts who have complete heart block. As explained by Pramod, it may be something related to the antibodies that damage the conduction system or inherent defects of the conduction system. So structurally, this is one group. So this will be The technical challenges here in a conduction system pacing will be the sheer small size of the patient. So how do we get around in implanting a pulse generator in a safe location so that we can achieve an endocardial pacing? The second group is operated congenital heart disease, in which Dr. Sai Kiran gave details about the different cardiac anatomies, the locations of various ventricular septal defects in patients with tetralogies, in patients with double outlet right ventricle. So the location where the normal conduction system is likely to be there, which is likely to be damaged during the surgical process, and how we circumvent it and try to capture the bundle a little beyond the place where the surgical harm has been done. The third one is an anatomically abnormal heart, which is prone for complete heart block, where corrected transposition is the clear standalone example. The brief discussion that Dr. Anindya and Dr. Sai Kiran were having briefly was regarding the pacing of the conduction system. Obviously, we understand that it's an inverted ventricle, so we are starting from the anatomical left ventricle and going towards the anatomical right ventricle. So the most scientific method of doing a conduction system pacing in that case will be truly electrophysiologically mapping the right bundle on the right side, left bundle on the left side with all their advanced gadgets, and then trying to exactly anatomically localize the lead position by drilling this 3830 lead, starting from the left bundle and going deep into the right ventricle, so that the ring electrode is going to be touching the left bundle and the tip electrode is going to be catching the right bundle. The moment we tell that itself, it puts a conventional pediatric cardiologist into jitters. I mean, these are all talking about tiny, fine wires with electrical potentials and then identifying. So then that means it creates. So in order to sort of reduce this anxiety, we will be planning a corrected transposition pacing tomorrow. Even though we have electrophysiological giants like Dr. Ullas, Dr. Anindya, Dr. Sai Kiran amidst our field, we still will be primarily going anatomically driven, like where the anatomy is. Dr. Sai Kiran nicely pointed out, if you are taking the pathway from the anatomical left ventricle that is located on the right side, so the mitral valve, anatomical left ventricle, pulmonary valve, so there is a mitral pulmonary fibrous continuity, and on the anterior surface of the pulmonary outflow tract, the conduction system is going to come and dive into the septum immediately below the pulmonary valve. So in the subpulmonary part of the septum. We know anatomically where the pulmonary valve is in a corrected transposition, because if I do something like an LV angiogram, I will locate it where it is. So if I come below the pulmonary valve, in that first 1 centimeter, if I am going to poke in my lead, I am likely to be closer to the conduction system. So this is anatomy driven approach rather than like extremely scientific electrophysiologically driven approach. Similarly, some of the operated forms of congenital heart disease where the heart may slightly be distorted, we will try to see. We will plan to do some 3 good different hearts. Nothing will be a normal heart, right? 3 different hearts, and we will try to see pacing tomorrow. I once again thank Dr. Sai Kiran for the lecture on showing the different congenital morphologies, congenital heart diseases. Now the next session is going to be an anatomy dissection, where we will try to see the region where we are supposed to do the conduction system pacing. So hello. Hello. Hello? Hello? Yeah, now it's still. First
One
one.
second, I'll just put on. I think put on this set diagram, this one. One second. Just try it out. Till the last is missing. The initially he put camera. Yeah, telling me they put from here.
Regular camera.
Yes, sir. It's like mobile phone only.
No, that's all. It is good. Is it okay? Yeah, yeah, whichever is good. It's fine. This should be okay, na? Oh, okay. That is okay. No, this one around videos. This is around this around light. Light source.
What about your camera? Will your camera will work?
Yes, it works, but you will have to be totally still while doing it.
I will do that. No, I will do that. Actually, I will do that. I think it will make it better. Whatever I am seeing, where should be. Can you just connect it once? Actually, in this meeting, we were also trying to test one gadget, which is called as the rods and cones from this agency, where whatever the operator is seeing, you also should be able to see. One of the problem about this, actually many surgeons will do that very commonly in surgical workshops. Quite often whenever they take their head out of the operating field and look at the monitor or look at something else, the people who are watching it will develop severe headache because it will keep going out. So let me try to concentrate as much as possible on the heart itself without turning to you. So it will be a test for finding out whether I am remaining still in this process. Please come quickly.
Anyways, we'll be both, sir, with your view also.
Yeah, no problem. You just get it down. Okay, now you adjust the camera. I want you to. No, this should not come in between. It should
be like this, sir.
okay, but you adjust it so that I want to see this portion. What I am touching now.
You connect it and then tell us how is the.
You have to turn the camera so that I will touch the places. That same place you should see there.
Turn the laptop this way.
No, laptop. Yeah, laptop.
No, it's okay. You project there in the screen. I will.
Oh, it's coming, so this will not be required.
Yeah, I'll take it out. Not a problem. I'll just keep. Yeah.
It can come here also. See, there is a.
That can come here. Also.
You switch it on. Your my.
Okay, switch it on. One second, sir.
Light is not an issue. I think that should be okay. Switch off that light alone. See, only that light is okay. This light should let it be there. I think it's okay. This light is good. I think. Or whether this will cover it nicely.
Yeah. Now you can magnify this.
Yeah, they can.
There are two views, so this is not zoomed yet, sir.
My
Not focused yet. Now you zoom.
Zoom.
you move
Zoom search visors. Can you zoom the view from the visors?
from. I have to do it or somebody.
No, they will only do. This is the search.
This is currently what we are seeing is search visor.
Yeah. Both you can zoom it.
Zoom the visors.
Perfect. Make it very big. Only the heart should be seen. All the tray should be out. Yeah, little. Even one more point bigger. Okay, that's good. So, you have to. No, I will just orient myself. Okay. So this is the superior vena cava, and this is the inferior vena cava, and here is the fossa valis. What I am touching is the fossa valis. If I have to, just give me one. So this is the region of the fossa valis. Your head, if you move out, rods and cones expert, I will be able to see it better. Yeah, thank you. So this is the region of the fossa valis. Now here, this is the coronary sinus. To expose a little bit of the heart, this is the septal tricuspid leaflet. It's a septal tricuspid leaflet. This is the coronary sinus. This is the arrow. This is the triangle of Koch, apex of triangle of Koch. This is the base of triangle of Koch. So septal tricuspid leaflet, apex of triangular Koch, tendon of third arrow, coronary sinus. So our AV node will be penetrating here, and it will be entering the ventricle through the anteroseptal tricuspid commissure. So I am going to open out a little bit more. So now this is the anterior tricuspid leaflet. This is the septal tricuspid leaflet. So the heart is going to penetrate through this anteroseptal commissure down. Now, in the process of conduction system pacing, our catheter will be entering from the superior vena cava down, and the initial attempt will be to get the guide wire through the tricuspid valve to go towards the pulmonary valve and get this conduction system sheath go deeper inside, so that the sheath will go into the pulmonary artery. So now, in order to show the septal anatomy a little bit better, I am going to now start cutting the heart, blade or something. So at this point, I am cutting the right ventricle. I will cut it and then orient it, and then I will get back to you. Briefly, you may lose your views. So now again I will orient you to the structures. This was the septal tricuspid leaflet. This was the anterior tricuspid leaflet. This is the anteroseptal commissure through which the AV nodal conduction bundle will be entering into the ventricle. We have got between the anterior tricuspid leaflet and the posterior tricuspid leaflet, actually the entire right ventricular anterior wall I have cut it out. So this is the anterior tricuspid leaflet and posterior tricuspid leaflet. The junction between the anterior and posterior tricuspid leaflet will be guarded by a group of chordae. Majority of them are cut, but I am just retaining one to show this is the anterior papillary muscle. This anterior papillary muscle is the structure through which the electrical conduction courses from the conduction bundle here, goes down the septal band. Septal band is also called as septomarginal trabeculae or SMT. So it goes down the septal band. The septal band's distal end connects the anterior papillary muscle, and so the region where it is connecting the septal band and the anterior papillary muscle is the moderator band. I am going to cut the base of the anterior papillary muscle in order to show the moderator band now. So this is the septal band. This is the septal band, and the moderator band comes out between the septal surface to the RV free wall surface, and the anterior papillary muscle connects to the tricuspid leaflet. So the right bundle that courses down the septal band will course through the moderator band to the free wall. So many surgeries that involve infundibular resections, where you cut the various portions of the hypertrophied septal band or the hypertrophied moderator band, will result in peripheral right bundle branch block. If you are injuring the right bundle right at its beginning here, in the region of anteroseptal commissure where the VSD will be located, that will be central right bundle branch block. The way to differentiate a central right bundle branch block from peripheral right bundle branch block in operated congenital heart disease is, central right bundle branch block may be associated with left anterior hemiblock, may be associated with prolonged PR interval, may be associated with intermittent 2:1 AV nodal block. That means the problem is just infrahisian. Whereas if it is a peripheral form of right bundle branch block somewhere here, that will just be widened QRS complex without any axis deviation. That means no left anterior hemiblock, without any PR interval prolongation. That means it's not affecting the HV interval at all. So this is the central and peripheral forms of right bundle branch block. Now I'm going to expose more of the septum. In order to make things clear, I'm going to be cutting off the entire right ventricle anterior wall, so that we are seeing only the septum, because the septum is the region that is more important for us for our conduction pacing. So now if I go up into the pulmonary outflow tract, are you okay? I think what you are seeing is that screen on the yeah. So this screen now, the main screen now, this is the septal band. The septal band branches into the posterior division and the anterior division. So here this is called as a Y-shaped band. I'm going to make it a little bit more visualization of the septum, so that you see all the parts very clearly. I'm going to trim off some more portion of the right ventricle. So now this is the long septal band. Septal band branches the posterior division and anterior division. This posterior and anterior division now supports the outlet septum, and above the septum is the pulmonary valve. So this is the pulmonary valve leaflets. So I am lifting the pulmonary leaflets now, and this is the pulmonary valve leaflet. So our conduction system, we are putting in from the right ventricle, the sheath will go into the pulmonary annulus, and then with a counterclockwise loop, I will be making it turn towards the septum, and now we drag it down along the outlet septum and try to enter closer to this region of anteroseptal commissure. In order to avoid the His bundle and to plan our pacing a little on the left bundle, it's about a centimeter or so below the level of the His bundle, or it's about a centimeter or so below the anteroseptal commissure, so that we don't touch the leaflets, and somewhere in this region is going to be our drilling. So far what we are seeing is the right side interventricular septum. So the sheath will go into the pulmonary artery, it will come down with a counterclockwise torque, it's going to be pressing against the interventricular septum. We come down, anatomically target an area around this area 1 centimeter distal to the His bundle. Now how do we identify whether we are too much towards the right ventricular apex or too much towards the flow? In a right anterior oblique projection, if you are having a pacing catheter that you have already placed in the right ventricle, so this is a pacing catheter already placed in the right ventricle, the loop of this is going to be on the tricuspid valve. So if you target the first 1/4 to last 3/4 junction, or first 1/3 to last 2/3 junction, that area will be the region of conduction system. So your anatomical landmarks are going to be the pacing lead lying like this, and when you are drawing down this sheath, you come down to the place where you are 1/3 below the tricuspid annulus and 2/3 above the right ventricular apex, somewhere in this region. Projection on a right anterior oblique view. So what I am showing itself is something like a right anterior oblique view, because the entire right ventricle has been laid open from its inflow to the apex to the outflow in one shot. So from this, I am going to turn on to the left side of the heart and show the anatomy in relation to the left side, even though we won't be going anywhere closer. Our final target is on the left. So I am going to show the anatomy from the left side. So I am going to flip the heart now posteriorly, and so this is the left atrium. I am going to cut into the left atrium and enter the left ventricle. I will show you. Can you just lift it? Yeah, just lift it. So now I am opening the left ventricle. From the left ventricle, I am now opening along the posterior wall of the left ventricle and opening the entire So now I will show left ventricle from here. So now basically what I have cut is the posterior wall of the left ventricle. The posterior mitral leaflet has been cut into two pieces. I have retained the anterior mitral leaflet intact. So this anterior mitral leaflet, which is the large triangular leaflet, is separating the left ventricular outflow tract in which my forceps is going from the left ventricular inflow tract in which the forceps is currently there. So the inflow to outflow is separated by the anterior tricuspid leaflet. So if I have to see the conduction area, I have to cut the anterior mitral leaflet and go towards the intraventricular septum. So now I am cutting the anterior mitral leaflet in the middle and exposing out the outflow tract. I am going to make it a little bit more cut so that we see the conduction system in relation to the left side of the heart. Pull it out like this. I will just orient you to the left ventricular outflow tract now. This is the right coronary sinus with the right coronary artery going out like this. I put the forceps into the right coronary artery. This is the non-coronary sinus. This is the right coronary sinus, non-coronary sinus. This is the right non-coronary commissure. This region is the membranous septum. So this is the place where the perimembranous ventricular septal defect will be present. Okay, I have to push it a little bit out. Yeah. So this is the non-coronary sinus, this is the right coronary sinus, this is the left non-commissure. This is the region where the broad bundle of left bundle will be entering. This whitish, this area will be the rough region where the broad left bundle will be descending. Here is the region of bundle of His, and here is the region of left bundle. So our target location is in this area. So now I am going to just get One needle or something. Needle or taking. I'm going to be putting a, see this is the region of the anteroseptal tricuspid commissure, the place where I am touching with my finger. The lead is going to be drilled from this area and it has to go and touch the left bundle. So let's assume this is the septal, this is the anterior leaflet and this is the anteroseptal commissure. A centimeter down, I am advancing my conduction system lead deep inside, about 1 centimeter deep inside, so that my ring electrode will be touching the right ventricle and my tip electrode should be capturing the left bundle. Once again, I will orient you at this point. Just lift it. This is the right coronary cusp, this is the non-coronary cusp. This broad sheet of area is the left bundle. So our area of target is this. Our area of entry will be anteroseptal commissure 1 centimeter beyond the tricuspid valve, and between the tricuspid valve to the RV apex 1/4, 3/4 junction or 1/3, 2/3 junction. Even if I go, one more needle is there? Only one. Even if I put in the lead a little bit more inferiorly, like this is 1/4, 3/4 junction. Even if I put in a little bit inferiorly, like right now it is 1/3, 2/3 junction. I will be getting it in the region of left bundle. This whole broad area is the region of left bundle. The first 1 to 1.5 centimeter below the region of our target. So this is the we wanted to show. Apical lead is going to be somewhere here, whereas the conduction system lead is going to be somewhere here. Since this lead is 4.1 French, much slimmer than the conventional 6 French lead, the amount of tricuspid valve restriction of leaflets, the amount of fibrosis that it creates on the leaflets, the amount of tricuspid regurgitation, all are going to be substantially less thanks to this thinner lead. So this we have been so far dissecting a human heart. Now it will be easier for me to do this, the pacing like a penetration, if it is a soft new heart. So for that purpose we are now going to open a pig's heart. So this is now a pig's heart. I'm going to open out as I open and I start seeing the structures, I will keep showing you one by one. So now I am cutting the right atrial free wall and exposing out the region of the atrial septum. This heart was more macerated by the harvesting person. So actually a lot of portion of the outflow tract, right ventricle are all already cut. So straight away I will go into the heart and try to get the two septums out. The right ventricular part of the interventricular septum and the left ventricular part of the interventricular septum. So now I am so this is the right ventricular, whole right ventricle opened out. I'll start from the outflow tract. This is the pulmonary valve. This is the infundibular outflow septum. Part of the infundibular septum has been cut by a deeper cut. This is the septal band. The moderator band has already been cut. This is the septal tricuspid leaflet. This is the anterior tricuspid leaflet. So now we are into the anteroseptal commissure. So between this basal part of the tricuspid annulus to the apical port of the tricuspid annulus, 1/4, 3/4 junction, this is our area of penetration. Once again, to reorient, this is the septal tricuspid leaflet. I will lift the septal tricuspid leaflet. I will lift the anterior tricuspid leaflet. This is the commissure, and below that commissure, this is the region where we are going to be targeting. The same thing now I am going to flip the heart onto the leftward side. I am cutting the left atrium and trying to enter into the left ventricle. Again we are exposing the same region, anterior mitral leaflet, hold it, anterior mitral leaflet, separating the left ventricular outflow from the left ventricular inflow. I'll just cut off some of this free wall so that we get an uninterrupted view of the mitral valve. So we have the posteromedial papillary muscle, anterolateral papillary muscle. This is the anterior mitral leaflet. In order to see the left ventricular outflow tract, because our conduction system is on the left ventricular outflow tract, I am cutting this anterior mitral leaflet in the middle between the anterolateral and posteromedial papillary muscles and entering deep inside the left ventricular outflow tract. So I am cutting through the aorta. So this is the whole of the aorta exposed. Here comes the right coronary sinus, non-coronary sinus. I'm going to lift the non-coronary sinus. I'm going to lift the right coronary sinus. This is the non-coronary left coronary commissure, and this is the region where our conduction system is. So again, let us recreate. I'm now coming back to the right ventricle. I'm flipping the heart again and again in order to, because we are going to the same area from the left side and the right side. So this is, whenever I'm orienting the right ventricle, I'm orienting in the anatomical direction. Whenever I'm orienting the left ventricle, I'm putting it upside down, like a 4-chamber view of the heart. This is the leaflet. This is the region of the his bundle. So now I'm going to be putting in needles in the region of his bundle. So this is the his bundle region. I am entering very, very, very close. So the his bundle region is located in the junction of the septal tricuspid leaflet and the anterior tricuspid leaflet, or the anteroseptal tricuspid commissural area. This is the region that will be getting damaged by our perimembranous VSD devices as well as the VSD patches and leading to complete heart block. So now I am going to flip the heart onto the left side in order to see. This is the non-coronary right coronary commissure. Again I will orient non-coronary cusp, right coronary cusp, the commissure, and this is our his bundle. Now, if you look at the thickness of the septum, in the region of membranous septum, it is very, very, very thin. Any torch or something is there? Or some phone, you just put it below. Put the phone light. I'm now going to able to see that just above my needle, that area is looking very translucent, correct? Whereas below that needle, it's looking more muscular. That is the junction between the membranous septum and the muscular septum. So now I am at the junction of the membranous to muscular septum. That needle has penetrated. Thank you very much. So this is the region of the his bundle. So if I have to target the his bundle, the place where this lead has to go is here. It's here. But that area being so thin is not a safe zone. Stability of the lead will be poor. The ring electrode is not going to be touching the ventricle, and the ring electrode will be floating. So safer strategy is to go for the muscular portion. So here in the muscular portion, if I keep drilling, get me another needle. So the conduction system, I hope, sorry. Yeah. Instead of targeting the most basal part of the tricuspid annulus, if we target about 1 to 1.5 centimeter down, we will be reaching the region of left bundle. And this area is a safer area to target our lead. So I am going to be enlarging this tract that I have created a needle and try to put this electrode inside. Okay. So that's enough. So if I am targeting 1 centimeter distal to the region of his bundle, my green needle is in the his bundle, and my blue 305 sheath is in the region of conduction system. Now, if I go to this area, I will be on this area. These are conduction. We should not penetrate into the left ventricle. We should try to keep it within the septum. Are you able to get the orientation of non-coronary right bundle? A centimeter. This is the. So this is our not to come into the cavity of the left ventricle, but to stay within the interventricular septum. So this is for a structurally normal heart. Now comes the second question about how do we get a diseased heart. A diseased heart has to be very intuitive. Suppose if you know that it is a truncus arteriosus repair or a tetralogy repair, you have to anticipate that this entire portion is going to be patch. So you need to come down substantially down when you are drawing down the CS sheath with a mental plan to come far more down than trying to target somewhere here. So you have to keep on coming down well below. This is just a mental thought process about how long my patch is going to be there and how much I am going to come down. And once you reach a reasonable distance, what I am telling is how much you have to come down is based on your echocardiographic interpretation of the extent of the VSD patch, the extent of the aortic override, everything. If suppose it was an isolated perimembranous VSD that was patch closed, then the pacing will be somewhere here. If it is a large tetralogy outlet VSD, this area will actually be bulging, the patch will be bulging like this, because aorta will be originating here and the right ventricular outflow tract will be far more outside. So the amount of the dragging of the lead down will depend on the echocardiographic interpretation of how long and extensive is the VSD patch and how far away from the pulmonary valve is your. This we will be dealing with it tomorrow when we are dealing with corrected transposition. We will see that. Basically, the advantage of this anatomical locating the conduction system is, you know the heart, you know the anatomy, you know where the VSD patch is, and now you are trying to come posterior to the patch, posterior and inferior to the patch. Electrophysiologists will be going to the electrical potentials that they are generating in those areas. So we have so far seen the normal conduction system initially in a human heart and subsequently in a porcine heart. In the porcine heart, I was not able to show you the coronary sinus, triangle of cock and all, because the heart has been quite a lot macerated, like it was cut much more extensively. I'm now going to like come out of this view. So what is that? Okay. So any questions about the anatomy? See, the way in which we can take it out. Thank you. So the way in which we will be, majority of the pediatric cardiologists will have a good internal understanding about what is the heart, right? I cannot explain it in a very objective manner, but we all know that we have a concept about what is the anatomy of the heart. So when I am talking about pacing in a tetralogy of Fallot, pacing in a truncus arteriosus is different from pacing in an VSD. We know what. In tetralogy and truncus and all, there is a lot of override. So the septum substantially comes, the patch substantially comes anteriorly, so that you need to drag down the lead far more posteriorly. Whereas in a structurally normal heart, the extent to which you are dragging down is far, far less. The second difference is, in a patient who has already been operated, there will be some degree of distal conduction abnormalities also, like peripheral RBBB also, that if you start off with a patient who is a tetralogy of Fallot, who is having a combination of left anterior hemiblock, right bundle branch block and a complete heart block, or 2:1 AV nodal block, when you are trying to drill down a lead and trying to get the conduction pacing, you will still have a peripheral conduction system block. So that all the electrical targets about getting this QR pattern, R prime being larger in V1, may not, you may have to adjust your thought processes. If suppose in a structurally normal heart, if you come down on a conduction system pacing and you drill in one particular area and you start pacing the patient, and if the patient is having a QRS axis of say -30, that means you are actually trying to capture more posteriorly. You are capturing the left posterior fascicle. But if that patient was a partial AV canal patient, that is the normal conduction. So for example, if I have a left axis deviation of -30 in a patient where I have drilled a conduction system pacing lead, in a structurally normal heart, I will say that I am not capturing the left bundle, I am capturing the left posterior fascicle, whereas that is normal for a post AV canal conduction pacing. So all the AV canal conduction pacing will be left anterior hemiblock, like left axis deviation. And all tetralogy of Fallots post conduction system pacing will still continue to have some degree of RBBB, but that will be much narrower than what it was. So this is some of the anatomical differences that will happen in a patient with structurally abnormal hearts. So let us yes.
You said about the echocardiographic view in which we can see how much you want this to drag down in post-tetralogy.
Okay, I am telling you, in the echocardiogram, make your plan. On table you cannot make it. So you make your plan about how much. Let's talk about totally a new case. Yeah, let us assume that there is a corrected transposition, intact ventricular septum, complete heart block. We all know that aorta is left and anterior, pulmonary artery is right and posterior, and between the two is the septum, right? So our septum is going to be in a plane which is sort of sagittal. So that means on the right side of the screen you are going to have the left ventricle, on the left side of the screen you are having the right ventricle with a sagittal septum, and you have the pulmonary valve that is originating from here. So now I have put in my conduction system sheath from the RA through the mitral valve, and unlike in conventionally normal heart, there is not much of distance between the tricuspid valve to the pulmonary valve. Here it is like sharp turn. So it has entered into the pulmonary artery. Now you are, if you want to, like if you have a prior, let us assume a small puff of contrast in the left ventricle to delineate where the pulmonary valve is starting off. So now you know in an AP projection at what level is the pulmonary valve. So now you are dragging down the lead down. We know that in corrected transposition, the anterior AV node continues as the conduction bundle, meets the septum and comes down on the anterior part of the septum. So in a pulmonary, when you are coming down in a corrected transposition, the moment you come down below the pulmonary valve, within 1 centimeter you drill. Whereas that you won't be doing it in a normal heart. So we all know as pediatric cardiologists these differences. So you just need to orient yourself in the echocardiogram just prior to the procedure where the structures are likely to be, how much I have to drag down below the pulmonary valve, to get my target. The target is very abstract. They have very sound principles of getting clear potentials. Here it is very abstract. But the virtue of being a pediatric cardiologist, you will know that that abstract concept is very strong. So we will try to see tomorrow in a real live heart how much it fits into the situation. So actually Aparna was telling that it's quite long due for coffee. So we'll have a quick coffee and then Anindya will explain some of the basics about conduction system pacing. Sure.
Coffee will be served inside.
So, see now right now I have admitted two transpositions. Visruta should, by any chance if
Lab will start. We'll put Visruta in which lab, like in A or B, like Siemens or no, whatever it is, we will not use this particular catheters or
yeah, but suppose if there
It's not opening, no network connection. Why network connection is required? It's not in one drive. Let's send it again. No, not up. Ready? Start. I'll start. Yes. Good evening, everyone. Welcome everyone to the first ever Pediatrics ESP Symposium, which is again being held at our institute, which has been a pioneer in conduction system pacing. As we discussed, we'll make it simple, we'll keep it simple, and focus on how the implant has to be done by an interventional cardiologist or electrograms and electrophysiological concepts. As Shikumar sir just told, just explained the anatomy in such a detail, and he also showed how the catheter will go inside the RV and actually sit on the septum. We actually could not see the view where it actually sits on the septum, but we'll just see how the hardware which are available will help us reach there. So I'll start with the absolute very basics. Whenever we do an implant from the left side, for example, if we take a straight wire from the axillary vein, if you push the wire, the wire will go through the axillary vein, subclavian, SVC, RA, and most often it will go to the IVC, or sometimes it will go to the RV, sometimes even the RVOT. That's a straight route. That's for a plain wire. Now, if we have a catheter which can take us to the RV, it has to have a C curve. You can imagine my hand as the catheter beginning from the axillary vein, the proximal part of the catheter being my shoulder, and there is a C curve at the elbow which will guide you from the RA to the RV. So right side of the chest could be visualized as the RA, left side of the chest could be the RV, and my seam of the shirt could be the tricuspid annulus. So a primary curve, a C curve will take you from the RA across the tricuspid annulus into the ventricle. So if you push such a catheter, you will invariably go into the RV apex or again into the RVOT. But that is not our aim. Our aim is to hit my left chest. And it has to be perpendicular to the orientation of this C curve. So that's why there is a secondary curve. And these are the two curves which you can see, which is available in all available vendors. With all available vendors, you can see here. So there is a primary curve which will take you across the tricuspid annulus, and there is always a secondary curve which takes you to the septum. Now there are different vendors in the market. For the pediatric population, we want the hardware to be soft. We want it to be less bulkier, and that's where you can see on the left side, the extreme left is the Medtronic C315 his sheath. The secondary curve is more acutely bent, so when you actually take the lead inside the secondary curve, it straightens out a bit. So Actually, it has to be a perpendicular one. There is a perpendicular curve here also, but when you take the lead inside the sheath, it will straighten it out. And that's how you get a perpendicular orientation to the septum. So this is about the catheter. We'll go into the basics, a little into the detail of the sheath. The sheath has a hub. The hub has a flush port and it has a flag, this flag. So there is a specific use to this flag. If you see carefully, the direction of this flag is actually the same as the orientation of the secondary curve. So inside the body, we will have the fluoroscopy to guide you whether you are abutting the septum or not. How do you see it? You come LAO and you see that it is totally perpendicular to the septum. But what is LAO and RAO in our brain is not a true LAO and RAO for the patient, because hearts are rotated to variable degrees in different patients. What we consider an LAO which shows us total perpendicularity may actually not be true. What you may think this is the RAO, you are visualizing the RV septum, the RV aspect of the septum like this, but it may not be true. You may be visualizing it like this, because the RAO which we use is RAO 20 or RAO 30, which is actually not giving us a true picture en face view of the septum. So in that case, this flag comes into play. How the septum is normally oriented is in LAO 40 or 50, you get a perpendicularity in most often. If I need to get a perpendicular orientation of this sheath to this septum, my secondary curve has to be faced like this, has to be facing it like this. So outside the body, my flag has to be facing towards the right. If sir is the implanter, for example, if I am the patient, when he implants, and so what he needs to do is, he just needs to hold it in an anti-clock orientation towards the right. So the flag has to face towards the right. So with this orientation, if he keeps the sheath, it will be totally abutting the septum, as you can see. And if he releases it, it loses contact. I'll discuss how, we actually will discuss the implant technique tomorrow, but because it will be a big session, I'll cover some topics today. So another thing which needs to be kept in mind is there is a hole. The entry point is not at the center. As you can see, the hole is actually at one end. So if you, sometimes what will happen is, this lead is not the typical lead. The helix is always out. So the knife is out. If you try to push the knife at the center of this valve, it will not go inside. You will have to push with some force. And if you do that, it will damage the valve. So what you need to do is, you have to figure out where this hole is and direct your lead towards that. How do you know it? You don't need to see it up close. It is opposite to the flag. If you see the flag is down, the opposite to it is the hole. So these are some small tricks to avoid that. As you can see, the valve is opposite to that hole. In that small picture, if you see, this is the location of the hole and the valve is sitting behind it. So there are different sheaths. The profile of this sheath is, it is a 7 French outer diameter. It supports, and the inner diameter is around 5.4 French. Compared to all other manufacturers, you can see the values are less. If you see the Medtronic column, the outer diameter brings, we are not talking about the sheath. It is only the pre-shaped sheath, the one which is, we are talking about the pre-shaped. So this is pre-shaped. The outer diameter is 7 French, the inner diameter is 5.4, less of a lesser profile compared to all other vendors. And there is only one curve available. So sometimes what happens is, you will have to make a manual curve at the proximal end, depending upon the size of the heart. If there are dilated hearts, you will have to have a more open curve. If there is a small heart, you will have to make a small, you'll have to have more acute primary curve so that it takes you to an anterior location. Otherwise, if it's a dilated heart, a more open curve will take you to the anterior location. If it's a small heart, a more acute curve is required. Then comes the lead. So the lead, I forgot to tell you, the working length, that is the length from the hub to the tip, is 43 centimeters. So my lead has to be longer than 43 centimeters. So this is the lead, which is a very thin lead, which was actually developed for a pediatric pacing only in the beginning. It is not made for, it is not built for CSP. It was made for a pediatric pacing. It was just used, it was just taken from the cabinet and used for conduction system pacing, and because this was the only one, we have had the maximum experience. We have had the maximum experience with this lead. This lead is 4.1 French. So it is going inside a 5.4 French sheath. So the outer diameter, so the diameter of this lead is 4.1. The length is, various lengths are available, 69, 74, but what is the commonly used one is 69 centimeters. So 69 centimeters, and the sheath was 43 centimeters. So we have 26 centimeters extra. So that will account for some slack which you give at the end of slitting, and some length at the proximal end so that you can insert your slitter. So whenever you design a hardware for conduction system pacing using a long sheath, you need to have a lead at least 20 centimeters more than the working length of the sheath. Also, you need to see that this helix, which is already out, this, contrary to a common lead, does not have a lumen inside. So there is no stillet, and that's what makes it very flimsy. And that also is useful when you go inside the septum. How is it useful? Normally, in conventional leads, we take the helix out of the body. So that helix, the diameter of the helix is actually little less than the diameter of the body. So they are not isodiametric. So there is a step up. Normally what happens is, if this helix, if this were to be a helix, extendable helix, the body will be like this in conventional leads. So this diameter and this diameter will not match, and there will be a step up. So contrary to that, this has an isodiametric design. This helix is already out, and therefore, and so the design is, so it is 4.1 French throughout. So because of this isodiametric design, it is postulated, it is theorized that this will go easily into the septum. However, with increasing experience, we have seen that even if there is no isodiametricity, this also can go into the septum without any issue. So there are, like a normal lead, there is a tip electrode and there is a ring electrode. There is a tip pin, there is a ring pin. Normally when we do the implant, we want the capture morphology from the tip alone. So normally what you do, at the pocket, we connect the red to the ring and black to the periphery. Here what you have to do is connect the red to the skin, the black crocodile clip to the tip pin, so that it gives you the pacing only from the tip. Also you need to know, sometimes people say they ask the septal thickness before the implant. What is the septal thickness? So septal thickness in normal person 9 to 11 millimeters. But what is, and sir was saying about getting the ring inside. So how far is this ring away from the tip? So the tip is, the tip, which means the helix. Helix is actually 1.8 millimeters. So this helix is 1.8 millimeters. The distance from the tip to the ring is 9 millimeters. The distance of the ring is approximately 3.4 to 3.6 millimeters. So if we do an implant tomorrow and we see the ring also inside the septum when we do a septogram. I'll show you a picture that will be better. One second, sorry. So what distance do you think is this lead inside? This, there is a radio opaque marker. This black thing is radio opaque. So that is 1.8 millimeters plus the distance between them is 9 millimeters. 9 plus 1.8 is 10.8 millimeters plus the black is fully in, right? So that is 3.4 millimeters, 3.6 millimeters. So that makes it 14.4 millimeters plus there is some distance more beyond the process. So that makes it around 15 millimeters inside the septum. This patient had a septal thickness of around 12 millimeters. How is that possible? So that it goes in. We'll discuss during the implant. It is because, as we discussed, heart is not, when we think the septum, the catheter is oriented perpendicular to the septum, it is not actually perpendicular. It is at an angle, almost always. So what happens is we don't go perpendicular to the septum, we go oblique. And that's why even a 10 or 12 millimeter septum can accommodate 15 centimeter of penetrated lead length. So that we'll discuss, and what is during an implant, that also we'll discuss. So with this, we are through with the basic sheath and the lead. Then there comes the slitter. There's nothing much to talk about the slitter. It's a normal slitter only. I'll show you how the slitting is done. So again, when I take the lead and I want to insert into the sheath, it's opposite to this flag. So I'm not going down and poking down. It's just up and smoothly it should go. One more thing I forgot to tell, how to maneuver the sheath, that is also important. So how do you, this is an ox sheath, so it's not coming out. There was another sheath now with the lead inside it. So what, I'll show you the floor, that is more important. Whenever you sheath, whenever you slit, you have to give a slack. So this is how you give a slack. You just push the lead. So currently the sheath is here. Now we'll just pull the sheath back, feed the lead in, so that there is some loop of the lead inside the RA, not the RV. So the slitting the slack has to be given in a way that the loop is not housed inside the RV. It should be housed in the RA. Otherwise, it will cause some extra shearing stress at the lead, because if you consider this is the annulus, if it goes inside the septum like this, so there will be more shear stress at this junction, entry point at the septum. On the other hand, if you give the loop in RA, it will be a smooth transition. Okay. So the loop has to be kept inside the RA and not in the RV. The slitting is like this. Slitter has a groove, and then this is fixed to the lead. Now you take it, actually you should enter it, place it close to the hub of the thing, and you fit this opposite to the flag. So the slitting has to be opposite to the flag. You just have to hold the slitter and the lead stable, and just you will have to pull the sheath and it will automatically come out. So the hand which has to be kept stable is the one which is the right hand which is holding the slitter with the lead, and the only thing which has to be pulled is the sheath. So this is all about hardware, but now we will discuss something about conduction system pacing, which will help us understand the concepts tomorrow also. So this lead, this sheath again, we have one more sheath. Not there. So what we were discussing initially, how to go inside the RV. As sir told, we'll normally take a wire inside the RVOT, and this will be dragged over that wire into the RVOT. From that position, we will pull back. We will come from the RVOT and will place it in the area of the proximal septum, anterior septum. So how do we position? Do we just pull it back plain? How do we do it? Any idea? So if you pull it just plainly, there will be trabecles in the, not in the outflow septum, but in the mid septum. It will trap the tip of the secondary curve and will straighten it out. We don't want that because it is already a flimsy sheath. We want it to hold this secondary curve throughout the procedure. Also, if you want to push from a location, for example, we are not at a correct position, we want to go little distal. If you push directly, it will again bend the secondary curve inwards. So that is also distorting the secondary curve. So how do we reposition the sheath inside the RV? Is to disengage it from the septum. You remember my hand is the catheter, at the wrist is the secondary curve. How do we position? We have to disengage. How to disengage? We'll clog the catheter. So if you arm twist, if you twist my arm clockwise, it disengages. Then you push and pull, and then you release it. When you release it, it will automatically fall into the septum. To get the orientation better, what are we going to do? Anti-clock. Anti-clock with the flag towards your right. You are doing the implant. Anti-clock with the flag towards the, so it will be like this. I need a better, there is one more sheath, no? There is one more sheath. So you make it more anti-clock so that it aberts the septum. So how do we move inside the RV? We clock it, disengage, pull, push, leave it. When we are pulling from the RV OT, it may happen because, as I told, it is the anteroseptal commissure, tricuspid commissure, which is the his bundle, and little distal to that is the left bundle. While trying to do that, we are actually not seeing a specimen. We are seeing it in fluoro, and we may not have a landmark for the tricuspid annulus. If we pull too much, we may fall into the RA. So from RA again, how do we go inside? Do we take out the lead and again put the wire? No. So what you can do is, you can again, so if you push again, you will hit the septal aspect, the septal tricuspid leaflet. We don't want it. Again you clock, push, it will go inside the ventricle easily, and then you leave it again. So how to maneuver is clock to disengage, anti-clock to engage. This is opposite of what happens from the groin. In groin we clock to make it to face the septum. So this is all about handling the catheter. Catheter. One more thing is the dilator. So we don't have the. I'll discuss this. We have one more catheter coming up. No? Yes. One sense. So where to start screwing is one question. You must have heard about hot CRT, lot CRT. So who is a CRT candidate? Actually, it will not come in pediatric population, but it is important to understand the target site. The ideal CRT candidate is a person with a left bundle branch block with LV dysfunction. So when we talk about hot CRT, I am trying to tell you that his bundle lead is able to correct a left bundle branch block. How is that possible? Because his bundle is some 10 millimeters proximal, and as sir told, we have to go 1 centimeter down to get the left bundle. So if there is a left bundle branch block, how am I going to correct it with his bundle pacing? Any idea? So the answer is the level of block. If you take 100 patients with LBBB, if you take 100 patients with LBBB, there will be some patients who will have a block in the left bundle. There will be some patients who will have non-specific interventricular conduction defect, IVCD, which you say. So we are interested in patients who have a typical LBBB. Typical LBBB means block is in the conduction system. In the conduction system also, if you take those 100 patients, half of them will have block at the level of his bundle. It is because inside the, one second. It is because inside the his bundle, I don't know what is happening. It is because inside the his bundle, there is differentiation of fibers. There are fibers which are going to become left bundle on the left side. There are fibers which are going to become right bundle on the right side. So that's why this is the his bundle, and left bundle differentiates. So if you take 100 patients of LBBB, 46, as said in this study, will have a block in this portion of the left bundle, so intrahesian portion of the left bundle. That's how when we put a his bundle lead at a higher output, we can actually overcome the block. So you will ask, if I see a patient with an LBBB, how do I find out whether it is conduction system block? The patient is not going to tell me I have a block in the conduction system, right? So the block can be at the conduction, in the conduction system, maybe his bundle, left bundle, or in the peripheral. So we'll have to figure out based on the ECG. I'm saying this because that will also help in finding out what is the target site. Oh, this guy. It's not coming here. It is because of my problem. No problem. So I'll show it here. So in LAO view, if you have the septum like this, if this is the his bundle, and this is the left bundle, and this is the right bundle, I'm talking about how to find out whether a block is in the conduction system from the ECG, LBBB. So for discussion purpose, say for example, the block is in the left bundle. How will the ventricle get activated when there is a sinus rhythm impulse coming down? What do you think? Ventricle will get activated at its correct time, or it will activate late? It will be activating on the ECG at the same time only, because ventricular activation begins once the Purkinje is reached anywhere. So right bundle is still vacant. This highway is still open. It is blocked on the other side. So the impulse will come down at its normal speed from the his bundle to the right bundle. So initial activation of the ventricle will be rapid only. What will happen? We are discussing a patient who has a block in the proximal left bundle, but otherwise other portions of the conduction system is actually normal. But impulse is not able to cross the block. So left bundle is not getting activated antegradely. So LV is not getting activated initially, only RV is getting activated. How is the left ventricle going to get activated? It will, the right bundle from the Purkinje, it will send out impulses everywhere. It will cross the septum. Inside the mid septum there is no conduction system tissue. It will cross the septum and it will ultimately reach the non-diseased distal portion of the left bundle, distal to the block. So once it reaches the left bundle, again it will be fast, right? Slowing, it is the transeptal myofascial slow conduction. So that leads to a notch. So what is the definition of typical LBBB? Typical LBBB is, it is not what we normally study. It is not more than 120 milliseconds. It is based on QRS duration more than 140 in males, more than 130 in females, V1 showing QS. We used to learn previously William, W in V1, M in V5, V6. That is not the criteria of typical LBV. QS in V1 or a small r big S in V1. And the third, and which is the most important criteria, is the presence of mid-QRS notching. The mid-QRS notch is because of, oh, now it's coming. Is because of slow transeptal conduction. So this is an example of a typical LBV. And this mid-QRS notch has to be there in more than equal to 2 contagious leads. Contagious leads means 2, 3 AVF, V5, V6, 1 AVL, like that. So if you see this ECG, this patient has a QRS duration. If you say it's a male, the QRS duration is 1, 2, 3, 4, 160 milliseconds, correct? The V1 characteristic is there is a small r, big S. And there is a mid QRS notch. So there is a mid QRS notch there in V4, V5, V6. Can you see there? In lead AVL also there is a mid QRS notch. So this defines a typical LBV. If you ask me, can this patient be corrected with a conduction system pacing? Yes. On the other hand, if you consider a patient who has you must have heard about Cabrera sign, Chapman sign. All these are peripheral delays, non-specific IVCDs. How will you recognize that? The slur or the notch will be on the initial portion or in the terminal portion. One is Cabrera, one is Chapman sign. These indicate that the level of block in a diagram is in the muscle, not in the central portion, not due to slow transeptal conduction. So this brings us to the target site. So for example, actually I will not, the criteria may be a little different for children. It may be 120, 130 only, sir. I am not so well versed with that.
It's just a pattern that we have naturally it will be
Yes. Yes. So the duration has been kept more than 140 in males and more than 130 in females because the size of the heart is more in males. So how do we decide what is the typical site for, what is the target site of going in? We have all heard about W in V1. So if there is W in V1, that is a good site. Why is that? Because again, we see the septum again, right bundle, left bundle. This is the sheath. We just discussed, right, in LEO view. It has to be perpendicular. Now the lead is coming inside and it is not yet screwed. Now we are going to pace. Now how is this similar to the last scenario? In the last scenario we saw an impulse coming from up and going down the right bundle. But there is no antegrade conduction here. We are going to pace from the RV side. And there is no guarantee that we are capturing the right bundle, right? So initial activation is through muscle only. We will consider muscle. And considering the conduction, and our target site should be what? If I go at that site, opposite side should be the conduction system. So I consider, for discussion's sake, that opposite to my fixated site is actually the conduction system there. It's there. And if I pace at that site, it will again go slow through the myocardium. And once it reaches there, and if it's a undiseased tissue, it will go fast. So if I pace, this is a pacing artifact. So the terminal activation is going to be rapid. Initial activation will be little slow because it's a RV myocardium only. I am trying to capture the RV endocardium, sorry. And there will be still, and ultimately it will reach the right bundle and some Purkinje and it will go because it's on the RV side, right? It will reach the right sided conduction system faster than it does on the left side. So what will happen is little slow conduction, even more slower conduction through the septum, and once it reaches the left bundle, it will be fast. So this is the reason for W. When we talk about W being there, it tells us that there is a conduction system exactly opposite to it. So that's where we go in. So that is the reason for W. Now, along with the W, there is some other criteria also. Before that, because we are discussing how to do it without the knowledge of EGMs, we have to understand the anatomy a little better. What Pramod sir had told, how we know the conduction system, how we visualize the conduction system. In RAO view, as sir told, AV node is actually a posterior structure in the epicardium. It will give his bundle will penetrate the AV membranous septum. It will come and divide into the, so we are not discussing right bundle by the way. So right bundle is out. Right bundle is on the right side. We are talking about the left side. It will divide into a left bundle, and left bundle will divide into a anterior fascicle, posterior fascicle, and in 20% of cases septal fascicle. Now, as sir told, his bundle is RAO view by the way, and after the annulus, 1 centimeter later, this is your target area. Now, I think many of you have not done conduction system pacing, but whoever has tried, sometimes it becomes very difficult to reach this target site. Sometimes you are stuck here. Sometimes you will be stuck here. If you pull, it will just jump out into the RA. So if you consider this entire septum, I am more likely to be in those blank areas rather than in those bundles. So then what? Should I be discouraged? Should I be ready with the mindset that I'll have to try 10 times before I actually reach a site which is a good one? It is not the case. As Pramod sir had told, the conduction system is not like that. It is actually a matter of pride that it was actually an Asian who found it out. As sir told, his name was Sunao Tawara. He was a Japanese pathologist who had gone to Germany for a fellowship. He was given a project of examining the histopathological specimens of 250 postmortem cases of rheumatic fever, and what he found out was Ashkoff's nodules. So his Tawara's guide was Ashkoff. So it is known as Ashkoff-Tawara nodules, but no one knows his name because it was the guide's name which comes first. But that is not the most important contribution of Tawara. Tawara's most important contribution is AV node. He discovered AV node. Even more importantly, Purkinje discovered Purkinje, but what about the connections in between? He, in his seminal paper in 1900s in a German journal, he showed that as soon as the fascicles come from the bundles, they will give out branches. They will give out branches which will communicate with the branches of the same fascicle as well as with the branches of the other fascicles. So if you cross the mid septum, means upper septum, if you reach the mid septum, there will be no area. There will be no area of the septum on the LV side. There will be no area of the septum on the LV side where you will miss the conduction system. If you try for the proximal left bundle, there is a small, this is a small target. But if you actually go little down and if you penetrate deeper into the septum, there is absolutely no area of the septum on the other side which will devoid you of the conduction system. If you have to just reach on the other side, and definitely you will capture the conduction system. So if I show it to you on, this is the LO view. So this is a CT reconstruction. In the left lateral view, if you see the left conduction system, the LV free wall has been removed. The AV node is being shown as an epicardial structure. It is outside the glass case if you see. Then his bundle penetrates, and as you see, right bundle is going on the other side as the green structure. His bundle and left bundle is actually very small trunk. As soon as his left bundle comes out, if you consider my hand as the palm as the left bundle, almost immediately it divides into a narrower structure and a posterior fascicle which is a broader structure. So the posterior fascicle is the biggest target. So in this RAO view, no, that is not okay. So in the RAO view, the posterior fascicle is like this. and anterior fascicle is very small. So this posterior fascicle is the biggest target of conduction system pacing in real life scenarios, and we may not always get to this proximal left bundle. Same thing if I show it in a left LAO view. This is the septal profile. If you just cross the septum, there is no area of the conduction system. There is no part of the, you will not miss the conduction system at all. So this is actually a case where we did the his bundle and left bundle both. If I show it to you, this is the RAO view, RAO 30, which RAO 20 actually we use. And if I so the previous diagram is again this one, just to show you how, if you just let go of that ideal site which I was talking about, you will still capture conduction system, you will still do left bundle area pacing by actually capturing the conduction system after you penetrate deeper. So in RAO view, how it will appear, this is the RAO view. If I superimpose that specific diagram on this, in this view, the entire area, so if you consider proximal 1/3, distal 2/3, if you cross the proximal 1/3, you will always capture the conduction system. The conduction system is up for grabs. So this diagram already has been explained by Pramod sir and sir. This is not a true approximation, sir. I just wanted to show that if you go just distal to the proximal septum, this entire area is full of conduction system tissue. You may miss it at this site.
But this is the two leads are real life.
Real life.
So where do you think the first lead, the more leftward lead is the regular stillet lead, and
Stillet driven lead, yes, sir.
the other lead is the
Metronic lead, yes. That is because Boston Scientific has a this specific sheath takes you to the left bundle. For a his bundle, you need a U actually, sir. You have to come back. For a left bundle, you need to be penetrating deeper. This is okay. So ideally, to take us to the his bundle, it has to be U like this. So Boston Scientific has a custom made sheath for his bundle. So that helps. So we tried with that, sir. So this again is the same pathological specimen which was shown by Pramod sir in his diagram. So after the mid septum, there is thick arborizations of the conduction system, and it's a reticular network. Which was apical? No, it was not apical pacing. I'll show you. The target site we have decided, right? It has to have a W. What are the other parameters? Okay. So in here also we'll get here also, everywhere we'll get a W. So what else do we need to see? That we'll see now. So we are not talking about his bundle pacing anymore. We are talking about left bundle area pacing. You should understand that left bundle area pacing is equal to incomplete RBBB. How will you get incomplete RBBB? If this is the septum, if this is the midline, if I cross the midline, you will get a incomplete RBBB. You don't have to reach the left bundle also. If I cross the midline, it will be incomplete RBBB, and you can say I did left bundle area pacing, because according to this definition, there is a cloud of CSP which will include his bundle pacing, right bundle pacing, left bundle branch pacing. So left bundle area pacing has something which is outside the cloud of conduction system pacing. What is that? That is LV septal pacing. So what is LV septal pacing? If you cross this midline and have not yet reached the left bundle, that is also left bundle area pacing. But it will not be conduction system pacing unless I actually demonstrate you have actually caught that. How will you demonstrate that? That also we'll discuss. We don't need to have a EP. You can do it based on your hemodynamic screening ECGs also. So there is something called deep septal pacing also. If you just penetrate till this level, you will still have a LBB morphology only. It will be narrow QRS. Sometimes you must have seen, you are trying to go in, you get a narrow QRS, you are happy, it's not his bundle, it's not QRBB, it's not incomplete RBBB, still you are happy because it's deep septal pacing. Because if you pace from here, near simultaneous activation, both bundles will get activated simultaneously, and it will be a narrow QRS. The only problem is there will be a delta. Delta because you are capturing the myocardium here, right? So the QRS will start forming as soon as you pace. Now it's coming. So previously we were discussing where to screw in, and that site was based on a W in V1. Now where I told you, sorry, here only will show. So we just discussed that after this point everything is conduction system tissue, right? But I am not telling you to put the lead here. As said, someone said it was appearing apical. So am I happy by putting the lead here? No. So select a site. I will select a site based on precaudal transition. I will select a site based on axis. So what should be the axis like? Be like, I want to avoid a more apical location. I want to be here. So how will I recognize on the ECG that I am at a little proximal location? What is in the apex? V5, V6. So if I am more towards the apex, so for example, if I put my lead here and V5, V6 is here, so that specific lead is visualizing activation from this pacing site in a way that more heart is actually away from the, so the majority of heart is away from the lead. Only a little portion of the heart is towards it. So if you pace from this side, how will the V5, V6 look like? R will be small, S will be big. It will be like a fascicular VT if you actually go to that site. So I don't want that. I want to be in the proximal site. So you keep it in mind, I need a good precaudal transition, like how it is in my body. So ideally by V3, V4, sometimes it is difficult to reach a proximal site. If there is a regular implanter, he will know. So a minimum requirement is at least V5, V6, R more than S. So we should be okay. What else do you want? You want a normal axis also. What is a normal axis? Lead, every lead is positive except for AVR in our body, right? So if it is, one second. So in this RAO view versus I keep my lead here, this is a more anterior location. Anterior is superior location. So whatever is in the heart is the anterior is actually superior, whatever is in the posterior is inferior. So if I keep my lead in an anterior location, as sir had demonstrated in that area in his histological specimen, what will be the QRS axis in terms of inferior leads? So lead 2 is here, lead 3 is here, AVF is here. Sorry. So if I keep my lead here, everything will be positive. But because I am on the right side of the septum, which lead will be more positive, 2 or 3? 2 is this side, 3 is this side. I am pacing from the RV side of the septum, 2 will be more positive, right? So at this side, 2 and 3 both will be positive, but 2 will be more positive, right? So as opposed to this first site, if you place the lead more posterior, what will be the morphology? Again, 2 and 3 both will be negative because the vector is moving away from that. If I place it in the middle, so 2 will be positive, 3 may be isoelectric or may be negative. So this is how I find out. I want 1 second. Sir. One second. I want a site. When I pace, don't look at the electrograms. I'm sorry. But you should focus on lead V1. This is V1. V1 has a notch. How is the lead 2? It is positive. How is the lead 3? It's negative. How is the AVL? It's positive. AVR is negative. And the precaudal transition is where? In V5, V6. So ideal site would be 2, 3 both positive, 2 more than 3, but not always possible. So easy to remember, inferior lead discordance, 2 positive, 3 negative. AVR, AVL discordance, like how it happens in our body. AVL is positive in our body, AVL is negative. So inferior lead discordance, AVL, AVR discordance, W in V1, and a good transition. If you can get a transition by V3, very good. Sometimes not possible, as this case, we got a V4, V5 transition only. And what was this site? So I will try to position as proximal as possible using the same concepts, clockwise to disengage, anti-clock to engage. So if you see, how will you know you have disengaged? You will move clock as soon as you move clock, it will jump. The catheter will jump inside the RV. If you so it's jumping there on the right thing. It jumps. Then I pull back and leave it there. Okay. So clock to disengage, clock to disengage, anti-clock to engage. This was wrongly kept. Okay. So this is a picture of what we just discussed. On the right side, it's like an RAO view. If you pace left anterior fascicle 2 and 3, both are positive. If you pace the posterior fascicle 2 and 3, both are negative. In between, if you are 2 positive, 3 negative. So you should not worry about the axis except for AVL-AVR discordance. You just should avoid an apical location. So the target site is notch in V1, a good transition, and a proximal location, as we discussed, precaudal transition only. You should not worry about, I could not get a lead 2 positive. It is not always possible. If in this diagram, I should not be here. I should be proximal to this. Even if I don't get it here, ultimately I'll get it here also. And that also will lead to a QR if you penetrate deeper, if you penetrate the midway of the septum. And that is called left bundle area pacing. That may not be conduction system pacing. So we'll stop here. Tomorrow morning, sir, I'll again run this briefly and actual implant, sir.
Actually, some of the points that Dr. Anindya is telling will be extremely useful when you are a solo operator in your own place, where nobody else is there to guide you. You have to take a decision about, is my target correct or not? So I think all subtle points that he is telling are very crucial. I'm sure tomorrow when we are implanting also, I'm going to request Anindya and Ullas to keep on telling. We will connect to 12-lead ECG and we will keep showing you the ECG patterns from the lab. They'll be far more giving you multiple tips to decide, is this target correct, is this target more posterior, is this target more anterior. They'll keep on telling multiple finer tips.
Yes.
So now actually there is a next one more session. There is a simulator. Dr. Anindya now will show you how you can practically manipulate the lead, how to get it. So there is going to be a fluoroscopic screen. You're going to be seeing AP projection, RAO, LAO, all the projections. Anindya and Ullas are all like veterans in this. So they will be able to guide you across. In fact, he will be demonstrating as soon as the lead goes and touches the RV, how are the potentials. As he drills through into capturing the LVVV, what are the potentials, everything. So you can feel free after Anindya does it. You can also go and slightly manipulate and go in this a veteran in Medtronic. He has been there ever since Medtronic started operating in the country, I think. Because I have seen him long ago, maybe 25 years before. So he is Medtronic. In fact, in my phone number, it will be written Medtronic Govind. Like I had seen him as, so he probably will be able to show the different views, RAO, LAO, AP, how to position all these things. So, tomorrow, Pramod, what time is the?
Start live at 9. 9. There will be one talk actually by Ullas and by India from 8 to 9. By 9 will be the sessions, and 9 o'clock the live will start.
Okay. Be here at 8 o'clock, because far more intelligent discussions will be done by electrical to talk about the various electrodes. And maybe 8 to 9 we will use for practically putting the patient on the bed,
So till the time they are setting up, how do you find a true LAO for a patient? If actually you have to find out. For defining a plane, you need to have 2 points, correct? So normally we put 2 leads in the body. One will go to the IVC, for example. The other one has a is the left bundle thing. So one atrial lead wire will be in IVC. You will keep it in the IVC, right? You want to keep the ventricle free, and you will have a TPI. The TPI will be in the apex, and apex is actually not apex; it's apical septum always. So you have 2 references. One is going from SVC to IVC. One is in the apex, and if you can get a view where both of these overlap, that is your true LAO. So for example, if I go LAO 30, which is not a true LAO, you may see the wire to be in a different plane than the tip of the TPI. But in an LAO where it is actually overlapping the tip of the TPI and the vertical wire, that is your septum. You can take it as a surrogate for the septum, and that is the true LAO. And if that is the true LAO, what is the true RAO? 90 degrees to that. So if true LAO you find by is like LAO 50, RAO will be RAO 40. And if you go to that RAO, then that, because in LAO 50 we will never be able to do the implant because the entire II will be on our face. So the RAO is more important, because in that true individualized RAO you will be assuming correctly that you are actually seeing the entire septum. And when you see the entire septum, you will know I have to go proximal here. Otherwise, if whatever RAO you do and the heart is like this, it may be at the apex here, but how will you see it in a projection? You will think it is proximal. On the other hand, if it is too much, then you may be at a proximal location, but how will be the projection? It may be in the apical. Falsely, you will get an impression that you are at the apical or basal location. So true RAO you can get from that, but that is not required always, and that's why we always recommend you fix 2 views. RAO 20 or 30 is okay, LAO 30 is also okay. So yes.
So just to save time, I pushed both the.
Okay. So as so what we will do is we will initially put the wire, not required. We'll put the wire to RVOT. We'll just track it. There is no dilator here, but I'll show you how to take it from the. So this is in RA, right? By the way, what is the angulation here? AP. It shows AP here.
Change here.
No problem. Where is the this thing? No, I'll do it. No, I'll do it. I'll do it here. No, but let them see. 1 second. So this is RAO 20, if I see. At RO 20, if I am caught in the RA, how do I go to the RV? So this is the lead. Lead is not out. How do I go to the RV? I clock it. When I clock it, it jumps, right? I push it, it goes to the RV. And if I release it, it will let it automatically fall. Can you see the tip again? If I do clock, it disengages. If I anti-clockwise, it engages, correct? Clock, disengage, anti-clock, engage. So whenever I decide to move, I will clock, disengage, push or pull and then release it. To make it more oriented, we'll see in LAO. We need to see perpendicularity in LAO, correct? So we will go, before going to LAO, in RAO only we'll push the lead. So how, in which view to position the lead? The lead will be positioned in RAO only because you can see the entire septum. You can visualize the entire septum and we want to be in the proximal septum. So if this is the true RAO, which it may not be, apex is here, base means tricuspid annulus may be somewhere in the middle and we are just distal to the valve. Maybe little, if you remember that diagram, are we anterior, middle or posterior? We may be in the middle, maybe little above the middle. So what if I pace from here? So lead is little out, I will take the lead little out. Okay, lead is out. If I pace from here, what will be the QRS morphology I am expecting? W, I don't have a control because only if it is opposite to the conduction system. But seeing this, what are you expecting? 2 positive, 3 may be positive or negative or isoelectric. Precaudal transition will definitely be at V4, V5 because it is definitely basal location. So one more thing, you may not have to pace also. If I poke, you see there are PVCs coming. What are the kind of PVCs? I'll do it again. So V1, can you see a W? Where is the transition? V4 there is a transition. Lead 2, you see, 2 is positive, 3 is negative, right? So we had actually, we know this from the anatomical landmarks. What else we need? What we decided? Inferior lead discordance. What else was discordant? AVR, AVL discordant. I'll do it again, you see. What is the AVL? Positive. AVR is negative, correct? So this is a good site according to me, right? It will be broad. It will not. This is not conduction system. Conduction system is, we have to start the journey. It is on the other side. So we'll go to LAO. Sorry. So LAO is 30. No, I'll do it.
No, you touch this.
No, I'll just do it just for this purpose. LAO 30. So this is 30. Okay. And whether I'm perpendicular or not, I can do a septogram to see. I need a puff. I need an injection. So injector. If I inject, so may not be fully perpendicular, but there is a good orientation. If I go again to the RAO, in RAO also you can see, if you don't believe you have the true RAO, if you push dye, you will see the tricuspid valve as a negative contrast. Then you will know actually whether I am, how close I am to the valve. So if I go to RAO 20 again, if I inject here also, actually it is not seen in real life. I'll show you an example. I have an example in my laptop in my presentation that I'll show you. So again I'll go to LAO. Sorry. So LAO 30. In LAO 30, what I'll do? This orientation is okay. Then I'll start. We will have to hold the sheath. This is not the true sheath. This is just a demo. With the left hand, you hold it. Press it on the patient's body so that this is fixed. Use your left hand to hold this lead and rotate with the right hand. If you rotate with the right hand, rotate, hold. Rotate, hold. In experienced operators, both you can be used to rotate. If I rotate, can you see PVC is coming? If I poke at an area with anything in the heart, that specific area which is being poked will give out a PVC. So what do you think? So anyways, I'm not constantly pacing, right? How will I know actually I reached the site with an incomplete RBBV?
You want to mag it?
We'll mag it, okay. No, it's okay. We'll see. What I'm saying. So what kind of PVCs do you expect when you actually reach the site? So it will become RBBV, right? So you cannot see the entire 12 lead, right? Only one lead you have to see, V1. In V1, if you see a QR, you stop. So I will rotate the lead, you just see the V1. And if you see a lead, if you see a morphology which is conducive with left bundle area pacing, you will have to tell me to stop. So there is a QR coming now, correct? There was a PVC, right? If I pace at that site, where is the pacing pin? ESA. Run test. So what is the morphology? QR, correct? It's like in V1, if you see, there is a small r. So if I rotate, this is not possible with this lead. For example, if I go deeper, see the r will come up more, and it will ultimately lose pacing because it will perforate. It's not. This is not the true scenario. In normal hearts, what will happen is r will become more. Ultimately, it will become RSR before perforating. So I'll come back again. So this is how you decide. You see a template beat. Template beat is what? Is a PVC when I have reached that site, and that PVC has to be of a RBBV morphology, incomplete RBBV morphology. This actually seemed a lot simple, but it may not be simple when you actually do it in a human body. One of you can come and we can just show it. Any one of you can come, sir.
You can't stand and do
Sit, please. You have to sit. So RAO2 position, right? So I have taken it out on the RAO. Maybe there it is in the SVC junction. No one is coming. Sir, please come. So because there is no flag, there is no up and down to the sheath. If you rotate it, sorry. If you rotate it 360 degrees, it will rotate like this. But this will not happen in the body, by the way. So we'll keep it this way. Okay, sir. So it's out. So go inside. Yes. So you just have, you forget about the lead now. Just push the lead. Not out. Just to the distal end. Okay. This is okay. So now you clock little bit. It is push. So this jump happened, right? That is the tricuspid and the crossing of the tricuspid. Leave it. Like this. So this is another site, right? Different to the site which I was. I was maybe more proximal. You are maybe more apical. If you do more, this it will go down. If you go, that because this is a simulator. In real body, it is not possible. If you leave it, it will fall on the septum. So if you keep it there, sir. Now you take out the lead. Take the lead out a little bit. What kind of flow? So same thing only. What I am saying, 2, 3 positive, correct? 2 positive, 3 positive, AVL, AVR negative. This is outflow. This is not a place where we will go. So you take the lead back. Sometimes you go to that site, then you will pace, and then you will realize this is not correct, because RVOT is not always so apparent like this. Sometimes you may think you are in an anterior location, but it is actually RVOT. So how will you reposition? You will clock, disengage, jumping, come back, anti-clock. So this is very proximal. This is proximal. Now push the lead, only the lead, not the sheath. You have no. Lead is the other. Yes. So you pull it back and push the lead, sir. Push the lead a little bit. Yes. No. This is okay. Push the lead. Okay. This is okay. So as we discussed, we may not be always perpendicular. If you are perpendicular, it will be NFAS, but it is not NFAS, right? Where is the tip looking? It's 1 o'clock. So ideal is 1 o'clock only. You should remember that 1 o'clock in RAO view. So we'll stop pacing because this gives you a false impression. Okay, because we will not be, we'll actually pace now. We'll pace and check what is the morphology, right? Whether this is okay to go or not. What do you think is the morphology? Again, it will be 2 positive, 3 negative, because it's this is a simulator. It will take you to that site. I'll show you another site where we'll see. So again, if I pace here, so actually this is a little above side than the last one. Can you see? Actually, this is still outflow. AVL, AVR are both negative. So he has to, so this appeared as if it's an anterior location, right? But it is not. So, sir, you pull back the lead. I'll stop testing. And, okay, this is also okay side, sir. You put the lead in, sir, just. हाँ दे दीजिए, कोई दिक्कत नहीं. Proximal है? हाँ कोई बात नहीं. नहीं, आपको लगेगा, आप जाइए, देखिए, क्योंकि आप अभी कोई जरूरत भी नहीं है. You can you see the morphology there? That is, it looks like outflow only. Is it? I'm not pacing actually. These are all PVCs, madam. Now we push. Now what is the morphology? V1 is the notch. These are all PVCs only, right? 2 positive, 3 negative. अगर मैं इधर फिर पेस करूँ, we'll pace here. Again, he actually he slided to that side. तो आप अगर फिर आप हमेशा याद रखिएगा जब भी आप पुश पुल, यहाँ पे तो आराम से हो रहा है, you will pulling it, it's coming. Always clock, disengage and then come. So you pull the lead back, clock the sheath, pull it back, release it और maybe थोड़ा सा ऐसा करके अब lead को अंदर ले जाइए, अब सिर्फ lead को अंदर ले जाइए. Now if we pace, what is the morphology? Again it is the same only. It is some problem with this simulator now. So what you will do is एक बार फिर से कहीं भी जाके, not changing ना, see, उसी तरह मैं और जगह जाऊँगा अगर मान लीजिए, if I go to a more posterior site, for example, अगर यहाँ पे गए, यहाँ पे क्या morphology होगा? 2-3 negative होगा. वहाँ पे आना ही मुश्किल है. Can you see in lead 2 is plus minus, 3 is negative. It will be like this, But in a real life scenario, this is also not bad. But this is more apical. Can you see V5, V6 is negative? Okay, this is not a good side. So we will come more proximal. Again, we will push this. इस साइड में कैसा PVC आया? 2 positive, 3 negative. Transition अच्छा है. मैं पेश करके भी बताऊंगा आपको. Okay. Inferior lead discordant, AVR discordant. V1 has a notch. There is a good transition by V4. This is okay. अब हम जाएंगे LO में. आप LO जाइए. LO 30. LO 30 में हम कैसे परपेंडिकुलर है? एक बार कॉन्ट्रास्ट देके भी देख लेंगे. इंजेक्ट. ठीक है, परपेंडिकुलर ही है ना सर. तो अब क्या करेंगे? अभी आपको जाना है अंदर, तो हम स्क्रू करेंगे. हम पे पेसिंग बंद कर रहा हूँ. तो अब क्या करेंगे? इस हाथ से दबा लेंगे इसको, बस इसी से दबा लेंगे, इसको पकड़ेंगे, उसको घुमाइए, बस घुमाइए. उधर आपके पास लीड घुमाने के लिए. नहीं देखा आपने क्या हो गया? इफ यू डोंट हैव अ गुड appreciation of the sheath and the lead, while rotating you may actually pull it. You are all focused on rotating the lead, but while doing so you may actually come out. So you have to see there, you have to avoid pulling it out. You should avoid pushing it in also. You, at the same place you just have to rotate. So push the lead little bit. Push. जाइए सर. नहीं अब जाइए ना अंदर. नहीं जा रहा अंदर. 1 second. हाँ नहीं अब अभी रोटेट करिए. गोविंद, मिस्टर गोविंद. हाँ इट हैज टू बी डन अगेन. कोई बात नहीं. हाँ विल डू इट अगेन. हाँ ओके. अब फिर से करते हैं. आ रहे हो, आता हूँ मैं. सिमुलेटर ज़्यादा डिफिकल्ट लग रहा है. More difficult cases. Okay sir. आप लीड को अंदर लीजिए थोड़ा सा, हाँ हाँ हाँ, लीड के पास, लीड को भी अंदर ले लीजिए, कोई दिक्कत नहीं। हाँ जाइए, कोई बात नहीं, सिर्फ शीट के साथ भी जा सकते हैं। ओके, क्लॉक, हाँ जाइए, हाँ जाइए, पुश करिए सर, ज़्यादा क्लॉक हो, हाँ ये पहुँच गया। अब यहाँ पे छोड़ दीजिए, एंटी क्लॉक कर दीजिए थोड़ा सा, 1 o'clock इज़ ओके, हाँ यहाँ पे ओके। आप पुश करिए थोड़ा लीड को, हाँ ओके, लीव इट। अब हमारे पास कोई पीवीसी नहीं आया, बट आई विल पेस। पेस नहीं हो रहा है, क्यों नहीं हो रहा? क्योंकि यू मे नॉट बी टचिंग इट, सो आप उसको थोड़ा और छोड़ दीजिए। अब गिरे ना आप उस पर, मतलब वो फ्लोट कर रहा होगा उसमें, दिस इज स्टिल आउटफ्लो। आप फिर से लीड को अंदर ले लीजिए शीट के, हाँ आप थोड़ा सा पीछे आ जाइए, क्लॉक करके पीछे आ जाइए, हाँ, और हाँ अब इसको एंटी क्लॉक करिए थोड़ा, हाँ अब लीड को निकालिए, हाँ। सो व्हाट इज द पेसिंग मॉर्फोलॉजी? नहीं आ रहा है, 1 सेकेंड। आ रहा था क्या? पीवीसीज आ रहे थे ना, 1 सेकेंड, विल डू इट। हाँ, सो अगेन, हाँ दिस इज आउटफ्लो ओनली, you will have to start it again. Actually this sometimes it's coming positive only if you make it, you will have to reset it again.
I think that would help the learners.
Okay, put the patch. But still, I think there is something wrong with this also.
You think so?
Maybe, because if I go down, for example, how is it pacing now? Now it's good. I think the patch may be helpful. So, यहाँ पे in this simulator we have a marker. This is the left bundle area. Okay. उसके बिना आप जहाँ पे जा रहे थे वो आउटफ्लो है, क्योंकि हाँ आरवी तो ऐसा होता है ना सर, अंदर घुसते ही आउटफ्लो चला जाएगा। हाँ हाँ, नाउ यू कीप इट हियर। सो द पेसिंग मॉर्फोलॉजी इज 2 पॉजिटिव 3 नेगेटिव, V1 में नॉच है, AVL पॉजिटिव AVR नेगेटिव है, ट्रांजिशन इज V4 इज गुड। सो आई विल टेक यू टू, आप ज़्यादा उसको एंटी क्लॉक करने से वो नीचे चला जाएगा, तो थोड़ा सा कम LAO स्पेशल। ओके, तो हाँ इस, हाँ तो आप एक काम करिए, इसको जैसे आपने ज़्यादा नीचे कर दिया सर, तो थोड़ा ऐसे आपने ज़्यादा एंटी क्लॉक कर दिया था, तो अभी इस पे रोटेट करिए आप। हमने इसको क्लॉक करके, पर रियल लाइफ में ऐसा होगा नहीं आपके पास, आप एंटी क्लॉक जितना भी करोगे वो ऐसे चिपका ही रहेगा उसके साथ। 1 सेकेंड, हाँ यू कैन सर। सो in real life when you make it more, it will be stuck there only. It will not go because there is not enough space in the RV. It is not a free playground in RV, right? You cannot just rotate like this. So in a real life patient, you can do as much anti-clock to abut to the septum, because if the RV is not so big, the free wall is just on the other side. But on the simulator, it is as if you are in a free playground. You just rotate and you are just rotating like this. It's not possible. So in the human body, you clock, you will disengage. But if you leave it, it will automatically fall like this. To make it better, abutting better, you just make it as anti-clock as you feel like, and that angle will be decided by the flag, because you are not seeing it properly in a specific LO. You decide that you will keep. So inside the body, it has to be like this. So the flag has to be to the right side of the implanter. Now you can go here. So again you have made it more anti-clock. So you make little clock. That is good. Okay, but little more clock. Bas. Now you go. You see the change in morphology. I am just showing it for the ease, because with this hardware you will not be able to continuously see the pacing morphology. You will have to rely on the PVCs. But यहाँ पे pace हो रहा है. What you will see, QRS is becoming narrow. The notch is moving rightwards. Then slowly R will come up. So we will have to tell him to stop. So we can stop now. There is a QR already coming up. Correct? आ गया ना सर? थोड़ा और जाइए अंदर, थोड़ा सा और जाइए. थोड़ा और जाइए, बस ये क्यों आ रहा है ना सर. So I was telling you कि this simply means I am a left bundle area pacing. But have I captured the conduction system? How will I know? I will pace from high output to low output. What will happen if I pace from high output to low output? If this is the septum again, if my lead is inside, see, left bundle is subendocardial only. If I reach it, if I go a little bit more, I'll perforate. But if, for example, this is the left bundle I have reached here, and I am checking high output to low output, the tech support who is there, I told him, please check the threshold. So at a higher output, what will happen? The cloud of activation is big, correct? The impulse is big. So what will happen? It will capture the muscle here plus the conduction system here. As I tell output 5, 4, 3, 2, 1, what will happen is this cloud is becoming smaller, right? So what will happen? It will capture only this area. At that moment, there will be a change in morphology. What will be the change in morphology? You don't need to worry about. If the QRS becomes little broader, little narrower, so there is a change in morphology during a threshold test. What does that mean? That means I am capturing two different tissues. And if there is no ischemic cardiomyopathy, which is not there in children, then apart from the myocardium, what is there in the septum is conduction system. So change in morphology during a threshold test, conduction system captures. So as sir did this here, so this is at 5 output. I am coming down 5, 4, 3, 2, just look for a change, 1, then minus, then 0.9, कोई change दिखा आपको? नहीं. Till threshold तक जाएंगे आप. But before just losing capture, if I go to vitals, if I freeze, I did not have the freeze, no?
Yeah, that's not, yeah, you have to freeze.
I have to freeze that,
it will
no?
not come up there.
It will not come up there, no?
Yeah.
So 1 second, I'll go again, CRM, I'll pace at 5. So 5 is capturing, right? I'll directly go to 1. This time I'll quickly go.
If you go make some 17 or 18 turns,
It will go, हाँ. So 1 second. So इसमें simulator में हाँ selective आ जाएगा. So ऊपर दिख रहा है ना quantity of turns लिखा हुआ है सर. मान लीजिए 18 टर्न्स जाएंगे, ये बोल रहे हैं 18 टर्न्स में. हाँ ठीक है सर, ये आ गया, राइट? हाँ. So now I am checking from high output to low output, okay? So 5, 4, 3, 2. आप देखिए बस, if it catches your eye, you tell. 1.9, 0.8, change, huh? Change, huh? Vital, freeze. It changed, right?
Yeah, it changed.
But I cannot go there, no? I'll go.
This will not be seen there.
हाँ, so I'll unfreeze. I'll do it again. I'll show it to you. फिर से करेंगे, ठीक है? 1 से नीचे आ रहे हैं. 1. Can you see it's narrow, right? I'll come down. Now 0.9. हाँ, did you see the change? Yes, I'll show you it in freeze. ये था 1 पे. जब मैं 0.9 में आया, how did it become RSR? It became RSR, right? So that means I am. So what you can imagine, what is happening is, I'm actually on the conduction. But what am I doing? I'm capturing the left bundle plus the myocardium. At a lower output, what is happening is I'm capturing only the left bundle. So there is an RSR. Where is it? Oh, you are not seeing it there, huh? This image will not come.
Yeah, it will not come.
It will not come. So if I just show you here. So this was at 1. There was a QR in V1. Correct? Where we actually stopped screwing, right? But as I decrease my output, what is the morphology? RSR, right? Can you see there is a change in morphology from this to this side?
No, I think they can see the morphology change in this.
In this itself, huh? Okay. But
The change of morphology
No, I have freezed it here, that's why.
Oh, yeah, this will not come,
This
but you
will-
can see the morphology change.
So this is RSR, na, Abhi. I will increase the output 1 second. I'll show it to you again. So this was at 1. Can you see the change in morphology? This you will see, something like this you will see. So this is QR. अब मैं नीचे कर रहा हूँ. Could you see the change? RSR आ गया. So if you see any change in morphology, that means you are capturing 2 different tissues, and that's it. Conduction system basically. That's it. So we'll again try with other people.
And if you want to show, most likely you will see the left potential. If you want to stop pacing.
So there is. Have you ever heard about something called LVAT, left ventricular activation time, interpeak interval? So we'll just see that. Let's do this now. Tomorrow we'll discuss.
Yeah, okay.
LVAT. So anyone next, if they want to come?
Yeah.
Please. Mr. Govind, will show them, no?
Yeah, I will, make them do that.
Sure.
So they can come in back. We can do it until 8:30. They can have dinner and come back, or come back, do this and have dinner.
I tell. So the dinner is ready. Few people can stay back and check the simulator. So some other people can go have the dinner, and we can do it in batches.
We can be there until 8:30. The simulator will be there until 8:30. You can have dinner and come back, or how?
Yes. Sir, QR is also RBB, incomplete RBB pattern.
How will it be, sir? Q is indicating LV, sir.
Huh?
Q is indicating LV and R is indicating RV. QR pattern.
So R is indicating RV.
Yeah. Q is
Because it's
indicating
the lead. V1, no, we are seeing V1. V1 is RV. V6 is LV. So when we talk about LVAT, left ventricular activation time, we see it in V6 because V6 is representing LV. So we'll see that tomorrow.
Normally also QR we can take it as RV, sir.